Safety and infection control. The practical vocational nurse contributes to the protection of clients and healthcare personnel from health and environmental hazards. The practical vocational nurse must be able to identify client allergies and intervene as appropriate, verify the identity of client, assist in or reinforce education to client about safety precautions, evaluate the appropriateness of healthcare provider order for client, participate in preparation for internal and external disasters, for example, fire or natural disaster, use safe client handling, for example, body mechanics, use transfer assistive devices, for example, gate, transfer belt, slide board, or medical lift. Identify and address hazardous conditions in healthcare environment, for example, chemical, smoking, or biohazard. Acknowledge and document practice error, for example, incident report. Follow protocol for timed client monitoring, for example, restraint or safety checks. Implement least restrictive restraints or seclusion. Assure availability and safe functioning of client care equipment. Initiate and participate in security alert, for example, infant abduction or flight risk. Identify the need for and implement appropriate isolation techniques. Use standard universal precautions and use aseptic and sterile techniques. Accident, errors, injuries, prevention. Patient safety and the prevention of injuries is a high priority need. According to Maslow's hierarchy of needs, patient safety and security are the second highest human need after the biological and physiological human needs. The nurse's focus on safety is integrated into all aspects of nursing care. The publication of the report, To Err is Human, Building a Safer Healthcare Setting, states that about 98,000 healthcare consumers or patients die as a result of mistakes and errors, including accidents, every year in the United States while they are being cared for in our hospitals. The report led to several national, statewide, and local efforts, such as the annual publication of the Joint Commission on the Accreditation of Healthcare Organizations, JCAHO, National Patient Safety Goals to improve patient safety. These national patient safety goals focus on the current and most threatening problems relating to healthcare safety and how to prevent and solve them. For example, some of the hospital patient safety goals for the current year of 2015 include goals such as to identify actual and potential patient safety risks, identify patients correctly using unique identifiers, improve staff communication, including the timeliness of staff communication, including documentation, use medications correctly, use and respond to alarms correctly, such as bed and chair alarms to prevent client falls, prevent and decrease the rate of infections in healthcare facilities, and to prevent surgical errors and mistakes, such as wrong patient surgery, wrong site surgery, and the retention of foreign bodies, such as clamps, in a bodily cavity that was opened during surgery. Identifying client allergies and intervening as needed. Some of the commonly used terms relating to allergies and allergic reactions include antigen. An antigen is a substance that stimulates an immune response in the body that produces antibodies when it enters the body and stimulates the immune process by stimulating the production of protective antibodies. Allergen. An allergen is an antigen that causes hypersensitivity and an allergic reaction in the person. Antibody. Antibodies are a direct response of the body to an antigen. These bodily protective proteins bind to and destroy antigens. Anaphylaxis. Anaphylaxis is a severe allergic response that mandates immediate medical attention to preserve life. Anaphylaxis most often occurs during a second exposure to an allergen, like penicillin and latex. Nurses determine, identify, and document client allergies to medications, contrast media used for diagnostic tests, foods, and environmental sources, including latex. Nurses observe for and identify any possible allergies to the medications. For example, nurses collect data relating to past medication allergic responses. They also observe patients throughout the course of care to determine if the patient is experiencing an allergic response to a new medication. For this reason, nurses must be fully informed about the signs and symptoms of an allergic response to all medications that they administer. All allergies are documented in the nursing assessment and also on the medication administration record, in addition to other areas in the medical record according to the facility's policy and procedure. Many healthcare agencies also use allergy bands and/or barcodes with embedded allergy information to enable nurses to readily identify any allergies to medications. Similar to latex allergic responses, the degree, intensity, and seriousness of allergic responses to medications can be moderate or severe. Commonly occurring medication allergies include allergies to penicillin, which can be particularly dangerous and life-threatening, allergies to sulfonamides, and allergic reactions to cephalosporin medications. Commonly occurring allergies to radiocontrast media include allergies to ionic high osmolality contrast media and non-ionic low osmolality contrast media. Some of the risk factors associated with allergies to radiocontrast media include beta-blocker antihypertensive medications, the elder years, female gender, and a history of renal disease and/or heart disease. It is estimated that about 10% of people have a reaction to penicillin. Some of these reactions are an allergic response and others are simply a side effect. The first exposure to penicillin, referred to as the sensitizing dose, sensitizes and prepares the body to respond to a second exposure or dose. It is then the second exposure or dose that leads to anaphylaxis or anaphylactic shock. The signs and symptoms of anaphylaxis and anaphylactic shock, a type of distributive shock, are a massive collapse of venules and arterioles in the body's circulatory system, decreased cardiac output, histamine release, a drop in blood pressure, pooling of venous blood, laryngeal edema, respiratory distress, a rash, a rapid bouncing heartbeat, and death unless it is immediately treated. Like a penicillin allergy, allergies to latex and its effect on the body can vary among individuals in terms of its severity. For example, some clients may only be affected with an immediate local contact dermatitis, the least severe of all the allergic reactions to latex. Others can be affected with a delayed contact dermatitis, and still more can respond with a life-threatening allergic reaction, which can be signaled with itching and flu-like symptoms and progress to tachycardia, hypotension, dyspnea, chest pain tremors, and anaphylactic shock. The signs and symptoms of immediate and delayed contact dermatitis to latex include itching and burning of the skin and skin scaling that can extend the area of contact, such as the hands when latex gloves are used. Allergies to latex can occur after long use. Allergies can also occur with the first contact with latex. Some of the patients at greatest risk for latex allergies are those with some immunosuppressive disorder, such as HIV/AIDS, and those with asthma and eczema. It is also believed that those who are allergic to some foods, like avocados, are more at risk for latex allergies than others without these food allergies. Identifying and facilitating the correct use of infant and child car seats. It is estimated that infant and child car seats prevent death among infants by 71%. They prevent death among toddlers and young children under 3 years of age by 54%, according to the National Highway Traffic Safety Administration. Infant seats and car seats must be properly sized and properly installed in order for them to be effective against injuries and death. For example, rear-facing infant seats are always installed in the back seat facing the rear of the car when the infant or baby is less than about 2 years of age and about 20 to 30 pounds. Convertible safety seats can be both rear-facing and front or forward-facing. Regular seat belts can be typically used when the child is at least 40 pounds and about 4 years of age. Identifying client factors and environmental factors that impact on accidents, errors, and injury prevention. Accident, errors, and injuries can occur as a result of client factors as well as environmental factors external to the client. Some of the client factors that impact on accidents, errors, and injuries include level of development and age, lifestyle choices, level of cognition, physical status and condition, abilities to communicate with others, and the patient's perceptual and sensory abilities. Levels of development and age impact on safety and safety risks. For example, infants are more prone to suffocation, falls, and strangulation than other age groups. Toddlers are more prone to poisoning and drowning than others because they are curious and not aware of these safety hazards. Preschool children and school-age children have pedestrian traffic accidents and burns as commonly occurring accidents and injuries. Adolescents are often affected with the adverse effects of an illicit drug overdose and motor vehicle accidents. The elderly are prone to falls, automobile accidents, and accidental burns. Lifestyle choices also impact on safety. For example, Some may choose to live in a high crime area, to have a gun, to have a hazardous job or hobby such as tree trimming and cliff diving, and or participate in illicit drugs. These patient lifestyle choices place patients at risk for injuries and accidents. Level of cognition affects the patient's judgment and insight. For example, confused patients may drink a cleaning agent or another poison left carelessly and unsecured on the nursing care unit because they are confused, and they lack insight into the dangers of drinking cleaning agents and poisons. Patients' physical status may be impaired in such a way that they become at risk for accidents. For example, patients who lack functional abilities, balance, and muscular strength are more prone to falls than other patients without these disorders. Similarly, patients' emotional, psychological status may be impaired in such a way that they become at risk for accidents. For example, patients with severe psychological disorders, those who are sleep deprived, and those with high levels of stress and anxiety are more prone to incidents and accidents than those without these emotional problems. Abilities to communicate with others may affect their ability to read a sign that says "no smoking" when oxygen is in use. They may also not be able to report their safety concerns to nurses and other healthcare providers. The patient's perceptual and sensory abilities may impair the person's ability to see hazards such as a wet floor and to hear hazard warnings such as a train whistle when they are blind or deaf, respectively. Some of the environmental factors that impact on accidents, errors, and injuries include poor attention to the securing of medications and other chemicals, such as chemical cleaning products, wet floors, high glare floors, clutter, noise, and other distractions. The best way to avoid injuries and accidents is to eliminate all environmental factors that lead to injuries and also to know the patient and their risk factors relating to injuries and accidents. Nurses who know their patients and their risk factors can intervene with appropriate preventative measures. For example, the nurse who knows that the patient is at high risk for falls will routinely monitor the patient and maintain adequate lighting in the patient's immediate environment, including the bathroom during the nighttime hours. Recognizing factors related to mental status that may contribute to the client's potential for accidents and injuries. Similarly, patients' emotional psychological status may be impaired in such a way that they become at risk for accidents. For example, patients with severe psychological disorders and diagnoses, those who are sleep deprived, confused patients, and those with high levels of stress and anxiety are more prone to incidents and accidents than those without these emotional problems. Determining client and staff member knowledge for safety procedures. Nurses must inform and instruct patients about safety procedures in the healthcare facility and in the home. When patients are admitted into a healthcare facility, they should be oriented to their room, the nursing care unit, and necessary safety procedures. For example, newly admitted patients are shown and instructed about the use of their call bell, the nearest emergency exit, and the nearest fire alarm. Similarly, when a patient is cared for in the home, after an assessment of the home environment, all safety procedures including emergency evacuation procedures and emergency shelters, for example, are taught to the patient. Not only is teaching and instruction necessary, it is also necessary that the nurse confirm that the client has a full understanding of these safety procedures. Nurses, as members of the team, must also be able to determine staff's knowledge about safety procedures and report any knowledge deficits to the supervising nurse so that the proper education and training can be provided to these staff members. Verifying the identity of the client, ensuring the proper identification of the client when providing care. As we previously discussed, accurate identification is necessary during all aspects of nursing care. At least 2 unique identifiers, other than room number, must be used. Some examples of unique identifiers include a unique code number, the person's first, middle, and last name, and/or complete date of birth including year, an encoded bar with at least 2 unique identifiers embedded into it, and a photograph. Room numbers are never used as unique identifiers. Patients and residents often enter the rooms of other patients and residents, particularly when they are confused. Patients at the greatest risk for identification errors are patients who are confused, comatose, have a primary language other than English, and those patients who have an identical name or a similar name to another patient in the healthcare facility. For example, Mr. Smith and Mr. Smythe are at risk for identification errors when they are in the same facility. The proper identification of patients prevents many medical errors, including wrong patient surgery, medication errors, and the provision of incorrect treatments to a patient. Utilizing facility client identification procedures. Healthcare facilities have formalized policies, procedures, and mechanisms for patient identification. In addition to the use of 2 unique identifiers, some healthcare facilities also have patient identification wristbands that include any patient allergies. They may even have wristbands to alert staff that the client is a code patient or a patient who chooses to not have cardiopulmonary resuscitation. Monitoring client care environment for safety hazards and report problems to the appropriate personnel. Nurses must, on a continuous and ongoing manner, surveil the environment for a wide number and variety of safety hazards throughout the course of their shift. All safety hazards must be immediately reported and corrected unless the nurse can deal with a particular hazard without the help of others. For example, a puddle on the floor can be immediately eliminated by drying it off without the help of others, but a malfunctioning piece of medical equipment cannot be corrected by the nurse. The need of another, such as a member of the biomedical or maintenance department, is needed for the repair of medical equipment. Some of the most commonly occurring environmental safety hazards include wet and slick floors, high glare floors, unattended medications and chemicals, poor and absent lighting, cluttered and blocked hallways that cause trips and falls, the blockage of hallways that are needed for emergency evacuations, and electrical extension cords and/or frayed wires. Assisting in and reinforcing education to the client about safety precautions. Licensed practical nurses are often asked and assigned to assisting with and reinforcing education with the patient about safety precautions when the need arises. For example, when a licensed practical nurse observes a fall risk patient attempting to get out of bed without assistance, the licensed practical nurse will remind the patient to call for assistance prior to attempting to get out of bed. Removing fire hazards from the client care areas. Fire hazards, including electrical hazards that can lead to fires, must immediately be identified and corrected in the home and in the healthcare environment. Some fire hazards include extension cords, the lack of smoke alarms and/or working batteries, the lack of properly charged and inspected readily accessible fire extinguishers, the blockage of sprinkler systems, oxygen use hazards, and malfunctioning pieces of equipment that could catch fire. More about fires and fire safety will be discussed later in the internal disasters section of this review. Protecting the client from accidents, errors, injuries. The prevention of accidents, errors, and injuries is imperative. For example, the prevention and management of disturbed and aggressive behaviors protects other patients, staff, and visitors from injuries. Implementing preventive measures such as bed alarms and chair alarms can prevent falls. Observing the environment can prevent many injuries and accidents, and checking shower and bathwater temperatures prevent patient burns. Providing clients with appropriate methods to signal staff members. Many patients have the mental and physical abilities to use the nurse call bell system. However, there are many patients who cannot do this. Therefore, for some, an alarm system on the bed and chair may be the only way to signal staff. For obvious reasons, all call bells and alarms must be responded to immediately and without delay. Failures to do this can lead to serious patient injuries. Evaluating the appropriateness of a healthcare provider's order for clients. All orders for medications, procedures, treatments, and diagnostic studies, for example, must be deemed appropriate by the nurse before they are transcribed or carried out. All orders that are illegible, incomplete, and/or questionable must be clarified with the ordering healthcare provider. For example, medication orders must be appropriate in terms of the dosage, form, route, and time in terms of the patient's characteristics, needs, and conditions. Invasive and non-invasive treatment orders must be appropriate in terms of need and medical necessity. Orders for diagnostic tests and studies must also be deemed appropriate before they are transcribed and implemented. Emergency response plans. One of the major roles of healthcare facilities entail the authorship, review, and implementation of emergency response plans for all possible and anticipated circumstances. Many components of these internal and external disaster plans are driven by the regulations and requirements of external regulatory bodies such as the U.S. government, the states, and the Joint Commission on the Accreditation of Healthcare Organizations. The two major categories of disasters that require an emergency response plan are internal disasters and external disasters. Internal disasters are events within the facility that jeopardize the health and safety of patients, staff, visitors, and others. Examples of internal disasters include fires, utility failures, workplace violence, tornadoes, cyclones, hurricanes, and other severe storms and flooding, explosions and bomb threats, radiation contamination, and acts of terrorism and bioterrorism in the healthcare facility. External disasters are serious events which occur in the nearby community that leads to mass casualties and people in need of medical attention and care. A crash of a jumbo jet and a major train derailment are examples of external disasters. Tornadoes, cyclones, hurricanes, and other severe storms and flooding are examples of both internal and external disasters. For example, Hurricane Katrina is an example of a catastrophic event that can be considered both an internal disaster and an external disaster. It was an internal disaster because many healthcare facilities in New Orleans were adversely affected with flooding and power losses. It was also an external disaster because there were many injured and ill patients in the community that required care and services of the healthcare system. Other examples of external disasters include acts of terrorism and bioterrorism in the community, such as the Boston Marathon terrorist bombing and radiation spills and accidents. Identifying nursing and assistive personnel roles during internal and external disasters. Nurses, assistive personnel, and other personnel in healthcare facilities have specific roles in internal and external disasters, as outlined and detailed in the healthcare facility's emergency preparedness plans. It is highly important that all staff know their roles and responsibilities before a disaster occurs because there is little time to read a policy and procedure when a disaster occurs. Immediately and competently executed actions are necessary. Actions that must be taken for various internal disasters will be discussed now. Fires and fire prevention. Fire prevention in healthcare facilities includes the education and training of staff, smoke detectors, sprinkler systems, fire doors, and policies and procedures relating to fires and fire threats, including no smoking policies, oxygen and medical gases use, maintenance and storage, and electrical safety policies and procedures. The procedure for dealing with and managing patients during a fire is easily remembered with the acronym RACE. You must RACE when a fire starts. RACE includes these elements in correct sequential order of priority. Step number 1 is rescue everyone in danger. Get all clients and visitors out of danger by following the fire plan set up by the facility you work in. Step number 2 is pull the fire alarm. Step number 3 is to contain the fire in the smallest possible area by closing all windows and doors. This prevents the fire from spreading to other areas of the healthcare facility. Step number 4 is extinguishing the fire when it is small enough to do safely. Step 1, which is rescuing everyone in danger, may mean that nurses and other members of the nursing team must follow instructions for a vertical or horizontal evacuation of patients. When patients are moved from one level or floor of the healthcare facility to another floor, it is a vertical evacuation. When you move patients from one area of the floor to another area of the same floor, it is a horizontal evacuation. Elevators must never be used to evacuate because elevators are for the exclusive use of firefighters and the equipment that is necessary to extinguish the fire. All medical facilities and households must have fire extinguishers. The different type of fire extinguishers and their uses will now be discussed. A Type A fire extinguisher is used to put out fires of common solid things like paper, mattresses, and cloth, including clothing. This type of fire extinguisher is somewhat limited. A Type B fire extinguisher is used to fight oil, gasoline, and grease fires, including kitchen grease fires. It too is limited in terms of use. For example, a Type B fire extinguisher cannot be used to combat an electrical fire. A Type C fire extinguisher is used to extinguish electrical fires. Type AB fire extinguishers combine the uses of a Type A and Type B fire extinguisher. They can be used on solids like paper, wood, and cloth, as well as oil, gasoline, and grease. Type ABC fire extinguishers are a combination of A, B, and C uses. They are used for all types of fires. They are the ideal choice for home and in most areas of a healthcare facility. It is required for all fire extinguishers to be checked regularly and see that they are fully charged and ready to use in an emergency. Using a fire extinguisher is quite simple if you remember and use the acronym PASS, which is: pull the pin on the fire extinguisher, aim at the bottom of the fire, squeeze the trigger on the fire extinguisher to release the spray, and then sweep the spray from side to side over the base of the fire until it is extinguished. When a person has clothing that has caught on fire, the person should stop, drop, and roll. Tell the person to stop, drop, and do not run, and roll as you also cover the person with a blanket to smother the fire. Get low and go. If a room fills with smoke, smoke and heat rise, so get to the floor and crawl out. The major complications of utility failures are the abrupt cessation of electrical power to essential medical equipment, such as a mechanical ventilator, suctioning apparatus, and oxygen supplementation systems, as well as a disruption of communication systems. Telephone, fax, and computer abilities are hampered. Even the patient's ability to communicate with staff using their bedside intercom system and their call bell is inactivated. When this occurs, the nursing team must continuously visually monitor patients by walking up and down the hallways and also provide patients with other forms of communication, such as a mechanical bell. Workplace violence can occur among and between workers, patients, and visitors. Disturbed, aggressive behaviors that threaten others must be addressed by de-escalating the situation whenever possible and by preventing these episodes of violence with security measures, such as deterring video surveillance and security guards. When an episode of workplace violence is possible or actually occurring, the nurse must follow the procedures that address this internal disaster. The prevention and management of disturbed behavior will be discussed later in this course with a section entitled Psychological Integrity. Generally speaking, severe storms such as tornadoes and cyclones are addressed by moving to the center of the area away from windows, closing windows, curtains, blinds, and interior doors to protect patients from flying debris, and evacuating the area and/or building when you are officially told to do so. Explosions can occur as the result of both nefarious and accidental means. For example, terrorists may plant a bomb in the facility, and an accidental explosion of a medical gas can also occur. Additionally, bomb threats can be called into the facility. If you receive a bomb threat by telephone, stay on the line with the person as long as possible while you are alerting others to this threat. Staying on the line gives you time to collect data and information about the person, including their gender, where and when the bomb is to be detonated, and any background noises that may lead to the location of the caller. Again, radiation contamination can also occur as the result of a nefarious act of terrorism or by accidental means in areas such as the nuclear medicine department. All facilities have policies and procedures relating to exposures to radiation, including those recommended by the Centers for Disease Control and Prevention, CDC. The CDC recommends that everyone evacuate the area, remove outer clothing, place clothes in a plastic bag to contain the radiation, and wash or shower all exposed bodily parts. Many healthcare facilities have decontamination areas with showers in the nuclear medicine department and/or the emergency departments to use in the case of radiation contamination. Terrorism, such as what happened with the World Trade Center and the Boston Marathon, is described as the purposeful and terroristic use of violence and force against people and property. Terrorism can be done with mechanical means like an airliner or bomb, with chemical, nuclear, or radiological weapons, and also with biological pathogens. The latter is referred to as bioterrorism. Healthcare facilities respond to internal disasters and external disasters that occur as the result of a mechanical, chemical, nuclear, radiological, and biological means. Physical injuries that affect large numbers of people are triaged according to the severity of their injuries and their prognosis in terms of certain death or the possibility of sustaining life with treatment. Triage is a method of prioritizing care during massive external and internal disasters. Color-coded tags are often used. These tags alert the staff to the severity of all arriving victims and their potential for survival. Triage-colored tags that are black identify the expectant group of victims that is expected to die. This group of victims is given pain medications to provide comfort. Red-colored triaged tags are the immediate care group that requires immediate medical attention for life-threatening injuries. This group has a greater possibility of survival than the black-tagged group. The yellow triage color indicates that treatment can be somewhat delayed until the red group's needs are addressed. This group is referred to as the yellow-tagged group. Lastly, The green triage group, referred to as the minimal care group, has only minor injuries. Like the yellow group, their needs can be delayed. Agents of bioterrorism, their signs, symptoms, and treatments are too complex and extensive to cover in this review. However, you should be familiar with those that are most likely. Some of these agents include anthrax, botulism, plague, smallpox, tularemia, and viral hemorrhagic fevers like yellow fever and Ebola. General guidelines in terms of responding to a bioterrorism attack include the basic principles of isolation, standard precautions, cleaning, disinfection, and sterilization as indicated by the bioterrorist microbe. Participating in the preparation for internal and external disasters. Nurses must be highly prepared to fulfill their roles and responsibilities in terms of all internal and external disasters, including those just discussed. One way to prepare is to review the policies and procedures relating to your role on a regular basis. Another way to prepare is by participating in mock drills and practices within the organization. Some facilities have secret code names for disasters and other emergencies. These secret code names, like Code Blue for a cardiac arrest, communicate the nature of the emergency or disaster to staff without alarming patients, visitors, and others who are not staff. Whenever you hear this announcement, you must act as if it is a real emergency rather than taking it lightly. If you learn later that it was a drill, you have gotten the opportunity to practice. If you learn later that this announcement indicated a real emergency, you have acted in a way that you should have to fulfill your assigned roles and responsibilities. In addition to Code Blue for cardiac arrest, many facilities also use Code Red for fire, Code Gray for a severe weather storm, cyclone, or hurricane, Code Orange for a chemical spill, and Code Pink for an infant abduction. Contributing to the selection of clients to recommend for discharge in a disaster situation. Like triage in the community field, facilities have to determine which clients should be discharged and/or relocated should an internal disaster occur or an external disaster which requires the facility to free up beds for community victims who will be coming to the facility. In descending order of priority from the most severe to the least severe type of patient, the following clients should be selected for discharge and relocation. Medical unstable and unpredictable critical care patients are the most severe of all patients. They are not candidates for discharge and relocation except under highly severe and threatening intra-facility crisis and disasters as occurred among healthcare facilities in New Orleans. Stable clients who need assistance are the second priority. Therefore, stable patients are not discharged until the lowest priority clients are discharged and a continued need for more discharges persists. Ambulatory clients who need no assistance are the first clients to be safely discharged and relocated. Ergonomic principles. Ergonomics is a scientific discipline that addresses the human being in the environment to facilitate human well-being. For example, ergonomically designed computer mice and ergonomically correct chairs that curve to conform to our normal lumbar curve are examples of ergonomic principles applied to products that are used in the home and in the workplace. Body mechanics is the safe use of the body using the correct posture, bodily alignment, balance, and bodily movements to safely bend, carry, lift, and move objects and people. An example of a good body mechanics principle is to push rather than pull objects and people. Using safe client handling. Safe patient handling and the application of the principles of body mechanics protects the patient, and they also protect the nurse. Patients benefit because they are being lifted and transferred by one or more people who are using the strongest muscles of the body. Nurses benefit because they have avoided patient injury, and they have also protected themselves from sometimes severe and permanent injuries, particularly to their back. In addition to getting the assistance of another or using a mechanical life, nurses should follow these principles of safe patient handling and body mechanics. Take the time to do a little bit of muscular warm-up and stretching before you attempt to lift or transfer a person or object. Plan your approach before you attempt to do it. Explain what you will be doing and how you will perform the lift or transfer. Instruct the patient about what you will be instructing them to do. For example, tell the patient to bend their knees and press their feet into the mattress. Then, on the count of 3, tell the patient that they should push up on the top of the bed as you assist them. Even very weak patients can help you with a lift or transfer when they know what you are about to do. Remain as close to the person or the object, such as a large box, when you are about to lift and while you are lifting. Face the person or object that you are about to lift. Keep your spine, neck, and back straight and aligned throughout the lift or transfer. Do not twist. Tuck your chin in and keep your neck and head aligned. Maintain a wide and secure base of support by keeping your feet apart. Pivot on your feet in the direction of the move and not against it. Get a secure and good grip on the object or person that you are about to lift. Use the long and strong muscles of your arms and legs to lift. Do not use back muscles, and use slow, smooth, and non-jerky movements. If your facility requires the use of a back support and/or you choose to use it, please understand that these back supports are useful. However, they will not protect you unless you also use good body mechanics. Using transfer assistive devices. There are a number of assistive devices that can be used to safely lift and transfer patients. Mechanical lifts are used mostly for patients who are obese and cannot be safely moved or transferred by two people, and also for patients who are, for one reason or another, not able to provide any help or assistance with lifts or transfers, such as a person who is paralyzed. A gate or transfer belt is also used to assist with transfers and lifting. These wide and sturdy belts are placed around the patient's waist when they stand, transfer, and ambulate. They are very often also used for physical therapy. Slide boards are particularly useful to move a patient from one flat surface to another. These boards reduce friction and, therefore, make the move easier and less irritating to the patient's skin. Providing instruction and information to the client about body positions that prevent stress injuries. When patients are able to move themselves around in bed and position their own body, the nurse should observe the patient's position and alignment to identify any deficiencies. When a deficit is noticed, the nurse should assist the patient into the proper position and explain the rationale for the particular position. Assistive positioning devices such as pillows, wedges, and bolsters can also be used to prevent stress injuries and to promote proper bodily alignment. Some of the commonly used anatomically correct positions that are used by patients in bed are the Fowler's position. Fowler's position is a sitting position with the head of the bed elevated. The dorsal recumbent position and supine positions are positions where the person is lying on the back with or without a pillow for the head. The prone position is on the stomach. The lateral position is a side-lying position with the uppermost knee bent and often maintained in that position with a pillow. The Sims position is a semi-prone position. Handling hazardous and infectious materials. Hazardous materials are defined as those things that are not biological but still remain hazardous to human beings, including patients and staff. Examples of hazardous materials are chemicals and radiation. The U.S. Occupational Safety and Health Administration mandates that information about all hazardous material is readily accessible to workers, including those who work in the healthcare environment. Information about hazardous materials is found on material safety data sheets. These are published and distributed to the users of their products to fulfill the mandates of OSHA and to protect workers. Material safety data sheets, MSDS, include the name of the product, information about the product's risks, and measures such as washing the skin that must be taken when a person has been exposed to some risk relating to the product, and information about the procedures for using, handling, disposing of, and storing the particular product. Biohazardous waste is defined as biological waste that can be hazardous to humans. Items such as sharps and bed linens that are contaminated with blood or other bodily fluids, such as feces, are considered biohazardous medical waste. Identifying and employing methods to control the spread of infectious agents. In addition to other clinical methods to control the spread of infections and infectious agents, which will be discussed later, include things like cleaning and disinfection. The technical definition of cleaning is a manual removal of debris and material from a surface using soap, water, and friction or scrubbing. The definition of disinfection, on the other hand, is the removal of microorganisms, including infectious, pathogenic microorganisms that can cause disease and infection, from an item with the use of a chemical disinfectant. Clinical methods to control the spread of infections and infectious agents include standard precautions, medical asepsis, surgical asepsis, special precautions, and hand washing, all of which will be discussed later in this course. Identifying and addressing hazardous conditions in the healthcare environment. As with all other safety risks, nurses must identify, address, and report all hazardous conditions, including those related to chemicals, harmful gases, smoke, and the poor management of biohazardous waste. Demonstrating knowledge of facility protocols when handling hazardous and infectious materials. Nurses must be fully knowledgeable about and strictly adhere to their facility's policies, procedures, and protocols related to the storage, use, and disposal of all hazardous and biohazardous materials. Home safety. Identifying fire and environmental hazards in the home. Sadly, many homes in the United States are hazard houses. Nurses who provide care in the home must be acutely aware of these hazards. They must identify these hazards, and they must also address and correct them. Some of the most commonly encountered fire and environmental hazards in the home include poor electrical outlets, frayed electrical cords including extension cords, tripping hazards like scatter rugs and clutter, dangerous oxygen therapy practices, inadequate footwear, the lack of necessary non-skid bathing surfaces, the absence of grab rails and handrails, poor indoor and outdoor lighting, the lack of a fire extinguisher and smoke alarms, and hazardous food handling and food preparation practices. Oxygen therapy safety should include instructing the patient and significant others about the dangers of smoking, flammable materials, other electrical equipment, and open flames around oxygen. The necessity for placing a no smoking sign at all doorways and entrances, and the need to use only cotton fibers and not synthetics near the oxygen to avoid static electricity. Foodborne illnesses are quite common in the United States. Most, if not all, can be prevented. Escherichia coli and Salmonella are the most commonly occurring foodborne infectious agents. The elderly, the very young, the immunocompromised, and pregnant mothers are at greatest risk for foodborne infections. Some of the preventative measures to decrease the risk of these infections include hand washing, cooking foods like meat and fish to the proper temperature, labeling open foods with an expiration or disposal date, handling different foods such as raw meats, fish, and vegetables separately, and using the FIFO rule. The FIFO rule is first in, first out. The first foods in the pantry, refrigerator, or freezer are the oldest foods. Therefore, they should be the first foods out and used. The adequacy of lighting is assessed in order to determine whether or not the lighting in the home is adequate enough to ensure safety, particularly in areas such as the bathroom, the sleeping area, and outdoor areas. Many home care clients have weakness and functional impairments, so the home is assessed for the presence of handrails, grab rails, raised toilet seats, and other devices to promote safety and prevent falls. Additionally, a fall alert system should be worn by clients at risk for falls. All homes must have an adequate number of working smoke alarms and at least one carbon monoxide alarm. The batteries in these emergency alarms should be replaced at least every 6 months. The patient's home is also inspected and assessed for frayed wires, overloading of electrical sockets, and other electrical hazards, such as electrical items in the presence of water. Again, all deficits must be addressed and corrected. Determining the client's understanding of home safety needs. As with all aspects of care, nurses must determine the client's level of understanding in terms of home safety needs. Teaching should occur when a learning need has been identified. For example, when a home care patient tells you that he warms his carpet in the garage for half an hour before getting into it so it will not be cold, it is apparent that this client is not knowledgeable about the dangers of carbon monoxide and how it builds up in garages when cars are left running in this enclosed place. Providing the client with information on home safety. In addition to teaching patients about carbon monoxide poisoning, all other educational needs must be addressed. Some of the information that you provide to the client, in addition to the safety hazards just discussed, includes community-specific information about such things as the local evacuation route and emergency shelters that can be utilized by the patient as based on their healthcare needs. Reinforcing client education on home safety precautions. Nurses provide information, either orally or in written, printed form, including all the content covered above and the proper home disposal of syringes, which will be discussed later in this course. Restraints and restraint use. A restraint is anything that prevents a person from complete freedom to move about and something that cannot be easily removed by the patient, and one that is not a customary part of treatment, such as an intravenous arm board. Restraints can be physical and chemical. For example, a vest restraint to prevent a patient fall is an example of a physical restraint. A sedating medication to control disruptive behavior is considered a chemical restraint. Both restrict the person's ability to move about freely. Other examples of physical restraints are soft padded wrist restraints, a sheet tied around a person to keep them from falling out of a chair, side rails that are used to stop a person from getting out of bed, a mitten to stop a person from pulling on their intravenous line, arm and leg restraints, shackles, and leather restraints. Manufactured restraints, like a vest restraint, and improvised restraints, like tying a bed sheet around the client, were far more frequently used in the past than they are now. The Centers for Medicare and Medicaid and the Joint Commission on the Accreditation of Healthcare Organizations highly regulate restraints. All healthcare facilities should have a goal of a restraint-free environment. Although the goal is a restraint-free environment, this goal does not prohibit the use of restraints and/or seclusion for some extraordinary reason and with stringent policies and procedures. Demonstrating a knowledge of the appropriate application of restraints, safety devices. Knowledge about the appropriate application of restraints is in the cognitive domain and in the hands-on skills domain of knowledge. You must know the policies and procedures prior to and during the application of a restraint, and you must also have the skills to place the restraint on the patient. Restraints must be snug, but not tight. You should be able to slide 2 fingers under a restraint between the restraint and the person's body. Bony prominences should be padded to protect the skin. The restraint is secured and tied to any movable part of the bed or chair so it is not pulled snugger when the part of the bed or chair is moved, and the restraint is secured with a quick-release half-bow knot. The cognitive domain of knowledge related to restraints includes knowledge about alternative and preventative measures to prevent the use of restraints, using restraints as a last resort, using the least restrictive restraint possible, orders relating to the application of restraints, and the monitoring and care that must be done when a patient is restrained. The most common uses for restraints are to prevent falls, to prevent the patient from pulling out lines and catheters, such as central lines and urinary catheters, and also to prevent dangerous behaviors that pose imminent danger to the patient and/or others. In order to prevent the use of restraints for falls, a number of preventative measures should be used and deemed not adequate to prevent falls before a restraint for falls prevention should be used. Some of these preventative interventions, in addition to maintaining environmental safety as discussed previously, include bed alarms, chair alarms, more frequent patient monitoring and observation, keeping the call bell in place, responding to the call bell immediately, and anticipating the patient's toileting needs, particularly during the night when the lighting is low. In order to prevent the use of restraints, such as a mitten restraint or wrist restraints, among patients who are pulling on and dislodging necessary tubes, lines, and catheters, include covering and securing these devices as much as possible to prevent it and, when possible, placing these items outside of the view of a patient. The prevention of seclusion and restraint for dangerous behaviors includes all removal of all possible triggers, de-escalation of problematic behaviors, and separating the person from any triggers. Restraints are used only as the last resort after all possible preventative measures have been tried and they have failed. They are never used for punishment, and they are never used for the convenience of staff. A complete doctor's order is needed to initiate the use of restraints except under extreme emergency situations, when a registered nurse can initiate the emergency use of restraints using an established protocol until the doctor's order is obtained and/or the dangerous behaviors no longer exist. Restraints without a valid and complete order are considered false imprisonment. The minimal components of orders for restraint include the reason for and rationale for the use of the restraint, the type of restraint to be used, how long the restraint can be used, the client behaviors that necessitated the use of the restraints, and any special instructions beyond and above those required by the facility's policies and procedures. Implementing the least restrictive restraints or seclusion. The least restrictive restraint to correct the problem of falls and the dislodgement of tubes, lines, and catheters is used when restraints are necessary. Restraints, from the least restrictive to the most restrictive, are mittens. Mitten restraints that are used to prevent the dislodgement of tubes, lines, and catheters. Wrist restraints that are used to prevent the dislodgement of tubes, lines, and catheters. A vest restraint that is used to prevent falls as well as disturbed violent behavior. Arm and leg restraints that are used to prevent violent behavior, and leather restraints that are also used to prevent violent behavior. Following the protocol for timed client monitoring. When you monitor the patient or resident who is restrained, you must observe and monitor the patient's physical condition, the patient's emotional state, and the patient's responses to the restraint or seclusion. Is the patient safe? Are the restraints still in one place and safely applied? Are the patient's vital signs normal? Is the skin color, intactness, and circulation good? Is the restraint too tight? Is the patient comfortable and without any physical needs that you can attend to, like toileting, food, and/or fluids? Is the person confused? Is the patient or resident angry, upset, or agitated? Is the person afraid or fearful? The licensed practical nurse observes, monitors, and documents data and information about the patient's emotional and physical status, the reapplication and application of a restraint, and all the care provided to the patient in restraint or seclusion. The patient is monitored and provided with necessary care at least every half hour. Documenting the use of restraints and safety devices and client responses. Some facilities use restraint flow sheets to document and record the use of restraints and the responses of the patient who is restrained or in seclusion. When these flow sheets are not used, the nurse must document all monitoring and care elements in the progress notes. Checking for the proper functioning of restraints and safety devices. There are physical and psychological dangers associated with restraint. For example, a client may become entangled between side rails with a vest restraint and strangled to death. An agitated patient may become even more agitated with restraints. The doctor must be immediately notified when restraints and seclusion are not effective in terms of their intended function and outcome. Reporting of incidents, accidents, irregular events, and variances. Although risk management and performance improvement are similar and complementary in nature, they are also different in terms of their ultimate purposes and goals. The primary purpose of performance improvement, as previously discussed, is to improve the quality of care provided by the healthcare facility by proactively identifying opportunities for improvement and ways with which processes can be enhanced and improved in a blame-free and non-punitive environment to positively impact the outcomes of care and services that are provided to the patients. On the other hand, the primary purpose of risk management is to reduce liability and the legal financial consequences associated with patient neglect, negligence, and malpractice. It is reactive to errors, incidents, and accidents rather than being proactive in terms of preventing them. Data and information relating to risk management concerns are often documented and transmitted with the completion of a facility-required incident or accident report. Most of these incidents, accidents, and risks occur as the result of medical errors, including the untimely provision of care, suicides, medication errors, falls, hospital-acquired infections, infant abductions, wrong site surgery, wrong patient surgery, and retained surgical items. Reported risk management concerns are addressed individually and as soon as they occur. But these concerns are also tracked continuously over time to identify patterns and trends that are occurring. These dangerous patterns and trends must be reversed and corrected in order to prevent future liability. Identifying situations requiring the completion of an incident, event, irregular occurrence, variance report. Nurses must immediately report a client care issue, concern, or problem to the supervising nurse, the charge nurse, and/or the performance improvement or risk management department, according to the reporting policies and procedures of the particular facility. Generally speaking, all incidents, accidents, adverse events, irregular occurrence, and variances require the completion of a report that will be sent to the risk management and/or performance improvement department as per the specific facility's established policies and procedures. Simply stated, incidents, accidents, and events that must be reported and documented include occurrences that are not expected, not normal, irregular, and potentially or actually harmful to the patient, staff, visitors, and others. Variances or deviations from practice that lead to a quality defect or problem are reported. Variances can be classified as a practitioner variance, a system institutional variance, a patient variance, a random variance, and a specific variance. A practitioner variance is an irregularity that is associated with the care and/or service provided by a healthcare provider. For example, an untimely medical assessment upon admission is considered a practitioner variance. A system institutional variance is an irregularity that is associated with the care and/or service given by the facility. For example, the lack of necessary supplies and equipment to adequately and safely care for patients and the lack of staff education and competency validation are considered system institutional variances. A patient variance is an irregularity that is associated with the patient themselves and not the healthcare provider or the facility. For example, the development of a pressure ulcer secondary to the patient's immobility and poor nutritional status is an example of a patient-related variance. Variances can also be classified as random and specific. A random variance is a quality defect. An irregular deviation occurs as the result of some thing or factor that is part of the established process. Random variances occur each time the process is followed. A specific variance is a variance that occurs randomly. Both of these variances must be identified and corrected. Acknowledging and documenting practice errors. All nurses and other healthcare providers must identify, acknowledge, report, and document all practice errors without fear of punishment and reprisal. Despite the fact that the purpose of reporting errors is to improve processes to prevent future errors, many nurses do not report errors not only because of fear of punishment and reprimand, but also because they do not realize that a mistake has been made. When, however, a nurse knows that a practice error has occurred, they are legally and ethically responsible to acknowledge it, document it, and report it in the manner and on the form, such as an incident report, that is required by the specific healthcare facility or agency. Monitoring the client responses to an error, event, or occurrence. The priority when an error, adverse event, occurrence, or variance occurs is the patient and their physical as well as psychological health and well-being. After the priority needs of the affected patient are addressed, the nurse should complete the necessary reporting and documentation. The priority is the patient at the time of an error, adverse event, occurrence, or variance that leads to harm and/or potential harm. The safe use of equipment. Equipment safety and the safe use of equipment is dependent upon both user safety and equipment safety. User safety can be ensured when all users of equipment, including nurses, are instructed on proper use on all pieces of equipment and are then deemed as validated as competent to correctly and safely use a piece of equipment prior to using it, without direct supervision and guidance. User safety is also ensured when the healthcare provider asks for assistance and re-instruction when they believe that they are not competent to use a specific piece of equipment, as well as when they inspect the equipment prior to using it with a patient. Some of the safety inspection components include the inspection of the piece of equipment for frayed cords, malfunctioning, and documented evidence of preventative maintenance and safety inspections by those who perform these tasks. All equipment that is even possibly unsafe or questionably safe must be immediately taken out of service and sent to the department that is responsible for ensuring its safety. Following facility protocols and procedures for the safe use of equipment. All healthcare facilities have established protocols and procedures for the safe use of equipment. These include staff education, competency validation, preventative maintenance, and safety inspections. Most healthcare facilities prohibit the patient's use of their own equipment like a radio, television, or electric razor. Others permit it, but only after it has been inspected and deemed safe by personnel who have the knowledge and skills to do so. These personnel do not include nurses. This inspection is typically done by the maintenance or equipment department. Providing safe equipment for client care. Safe and effective equipment, such as electrical oxygen supplementation therapy and continuous passive motion devices, in addition to non-electrical equipment such as walkers, canes, and other mobility aids, must be safe and deemed safe prior to use. The rubber tips on a walker, cane, and crutches should be inspected often. All tips that are uneven or worn out must be replaced immediately. Preventative maintenance is done by replacing all tips at least once a month, even when they are not worn out. Clients, in addition to staff, must also be educated about the safe use of equipment, particularly when they are performing self-care in the home. Safety and security are closely aligned. Healthcare facilities have security plans, as mandated, similar to the necessity for emergency preparedness plans. Security plans are consistent with the regulations and recommendations of the Joint Commission, the Centers for Medicare and Medicaid, and the International Association for Healthcare Security and Safety. Some of the most commonly occurring security risks in healthcare facilities include infant abduction, client elopement, the entry of dangerous and violent people, and information data theft. Nurses must be fully knowledgeable about security plans and their assigned responses to security threats so that they can act rapidly and without delay. Even though preventative security measures, such as secured and alarmed doors and staff identification badges, are routinely used, there are times that these serious and dangerous events occur. Initiating and participating in security alerts. Similar to emergency preparedness plans, all nurses must be prepared to act with security threats and security breaches. One way to prepare is to review the policies and procedures relating to your role on a regular basis. Another way to prepare is by participating in mock drills and practices within the organization. Using the principles of triage and evacuation protocols and procedures. In descending order of priority from the most severe to the least severe type of client, the following clients should be selected for discharge and relocation. The need for this may occur, for example, when a shooter is loose in the building and on a rampage. Medical unstable and unpredictable critical care patients are the most severe of all patients. They are not candidates for discharge and relocation except under highly severe and threatening intra-facility crises. Stable clients who need assistance are the second priority, and, therefore, not discharged until the lowest priority clients are discharged. Ambulatory clients who need no assistance are the first clients to be safely discharged and relocated. Monitoring the effectiveness of security plans. The effectiveness of security plans can be monitored by determining whether or not security breaches were prevented with measures such as infant maternal alarms and whether or not security crises were dealt with. This monitoring and evaluation is often done by a committee such as the Safety Committee. Infection control, standard precautions, transmission-based precautions, and asepsis. Some of the commonly used terms and terminology associated with infection control include those relating to the chain of infection, the modes of transmission of infectious microorganisms, asepsis, types of infection, and personal protective equipment. The chain of infection includes the infectious microorganism, the reservoir or location where the pathogen lives, the port of exit from the reservoir, the mode of transportation from the reservoir, and the portal of entry into the person or host. Airborne transmission is defined as the mode or means with which a microorganism is moved and transmitted via air and inhaled into the respiratory tract by the susceptible host. These infections are found in droplets and dust in the air. Airborne precautions are indicated in the presence of a pathogen that is transmitted via the airborne mode of transmission. Contact transmission is defined as the mode or means with which a microorganism is moved and transmitted via direct or indirect contact with the infected person or an object that has been contaminated with the pathogen respectively. Indirect contact transmission is sometimes referred to as vehicle-borne transmission. Contact precautions are indicated in the presence of a pathogen that is transmitted via contact transmission. Vector-borne transmission is defined as the transmission of a pathogen from an animal or insect to a human being. Transmission-based precautions are special measures that are put into place to prevent the spread of infection. Transmission-based precautions are based on the pathogen's mode of transportation. Examples include contact and airborne precautions. Standard precautions are measures that are used to prevent the spread of infection among all patients whether or not they have a known infection. Standard precautions protect healthcare workers and patients from the spread of infection secondary to contaminated blood and other bodily fluids. Asepsis is defined as not septic. That is, asepsis is the absence of disease-causing organisms. The two types of asepsis are medical asepsis and surgical asepsis. Medical asepsis is defined as the absence of disease-causing microorganisms. Medical asepsis is often referred to as clean, which is more than sanitary. Medically aseptic techniques are used to maintain medical asepsis. Surgical asepsis is defined as the absence of all microorganisms. Surgical asepsis is often referred to as sterile. Surgically aseptic techniques are used to maintain sterile asepsis. Contaminated is defined as some contact with a microorganism. Sterile items and clean or medically aseptic items are contaminated differently. A medically aseptic item is contaminated when it comes in contact with pathogenic microorganisms. Sterile items become infected when they are touched with any item that is not sterile. Decontamination, according to OSHA, is defined as the use of physical or chemical means to remove, inactivate, or destroy blood-borne pathogens on a surface or item to the point where they are no longer capable of transmitting infectious particles, and the surface or item is rendered safe for handling, use, or disposal. Disinfection is defined as the destruction of pathogens, but not spores, using a chemical or physical means of disinfection. Sterilization is defined as the process with which all pathogens, including spores, are destroyed. Sterilization can be done with moist heat, a combination of heat and pressure, gas, radiation, and boiling water. An antiseptic is a germicidal solution that inhibits the growth of some microorganisms. Examples of antiseptics include hexachlorophene, iodine, alcohol, and antiseptic hand washes. Many can be used directly on the skin. A healthcare-associated infection is any infection that occurs during the time that the patient is being cared for in a healthcare facility. Most of these infections are infections of the urinary tract. Iatrogenic infections are those that occur as the result of some diagnostic test or a therapeutic procedure. For example, atelectasis after a diagnostic bronchoscopy is an iatrogenic infection. An occupational exposure is the exposure to a pathogen by a healthcare worker during the course of their work. Post-exposure prophylaxis is the prevention of an infection after an individual has been exposed to it. Personal protective equipment, PPE, is specialized equipment and attire that is used by employees in healthcare to protect against infections. Examples of personal protective equipment include gowns, gloves, masks, goggles, and respirators. Identifying communicable diseases and modes of transmission. Communicable diseases occur as the result of many fungi, bacteria, viruses, parasites, and prions. Prions are protein particles without nucleic acid that can cause neurological diseases like Creutzfeldt-Jakob disease and scrapie. Modes of transmission, or transportation, are the part of the cycle of infection that moves a pathogen from its reservoir to its susceptible host. There are several modes of transmission including direct, indirect, airborne, vehicle, and vector modes of transmission. Direct transmission occurs when a pathogen comes in direct contact with the susceptible host's skin or mucous membrane. Indirect transmission is the movement of an infectious agent from the reservoir to an object which is then passed to the susceptible host when the host touches the object. Droplet transmission occurs when a pathogen is spread with a spray or splash of infectious microorganism, which can occur when coughing or sneezing, for example. Airborne transmission occurs when the pathogen is carried in dust or droplets in the air. Measles is an example of a virus that is transmitted with the airborne mode of transmission. Vehicle transmission is defined as contact with an infection in things like contaminated soil and water. Vector transmission is the movement of the pathogen with live things like insects which infect humans with their sting or bite. Some patients are more susceptible to infection than others. Some of the things that increase the patient's or host's susceptibility to infection are high levels of stress and cortisol levels, old age, infancy, poor nutrition, particularly when the patient is affected with a protein deficit, the presence of physical disorders and diseases, immunosuppression, some medications such as chemotherapy and steroids, and some treatments like radiation therapy for cancer. Briefly stated, people get infections when their natural bodily defenses against infections fail. The human body's first line of defense against infection is intact skin. Other bodily defenses include the inflammation process and antibody-mediated defenses, including active and passive immunity. Active immunity is present as a response to an antigen. Passive immunity is present when antibodies to an antigen are present. Both active and passive immunity can be either natural or artificial. Artificial active and passive immunity are given with an injection of an antibody like immune globulin, which produces artificial passive immunity, and the injection of an antigen, which reacts with the formation of antibodies against the infection. This is artificial active immunity. Natural active and passive immunity occurs when the person gets the infection and later produces antibodies against it, which prevents future occurrences of this specific infection, and when the neonate naturally gets antibodies in utero during pregnancy. These immunities are natural active and natural passive immunity, respectively. When the body's defenses against infection are not sufficient to combat it, infections occur. The signs and symptoms of infection, generally speaking, are local and systemic. The local signs of infection, like the signs and symptoms of the inflammatory process, are site pain, redness, heat, swelling, and some bodily part dysfunction. The systemic signs and symptoms of infection include fatigue, chills, hyperthermia, prodromal malaise, tachypnea, tachycardia, nausea, vomiting, anorexia, confusion, incontinence, abdominal cramping, and diarrhea, among other signs and symptoms as based on the infection. For example, urinary infection signs and symptoms can include urgency, dysuria, urinary frequency, and hematuria. Respiratory infections lead to coughing, dyspnea, and adventitious breath sounds. Identifying the client's knowledge of infection control procedures. Clients must be knowledgeable about the principles of asepsis, the importance of hand washing, protective and transmission-based precautions, and standard precautions. They do not have a need to be knowledgeable about the complex terminology and scientific intricacies of infection control policies and procedures, but they must have sufficient knowledge about those infection control procedures that affect their personal health and well-being. They must be aware of the fact that infections are common during hospitalizations, in the home, and in the workplace. They must know the importance of immunizations in terms of preventing communicable diseases. They must be able to wash their hands in the appropriate manner. They must know about the procedures and restrictions associated with any transmission-based precautions and how it impacts on the healthcare staff, the patient, and themselves. They must also know what personal protective equipment is used and why it is used. Among other things, they must know how to apply basic infection control procedures when they are performing self-care, such as irrigating a colostomy and changing a surgical site dressing, for example. Identifying the need for and implementing appropriate isolation techniques. Contact precautions prevent direct and indirect contact transmissions of infectious pathogens like those found in infected wounds, infectious diarrhea, and infections such as herpes simplex. Droplet precautions are used to prevent the transmission of pathogens that are transmitted with a cough or sneeze. Therefore, face masks are indicated for these precautions. Airborne precautions are used for airborne transmission microbes like tuberculosis, which requires a negative pressure private room and a HEPA mask. Using standard and universal precautions. Standard precautions are infection control measures that are used to prevent the spread of infection among all patients, whether or not they have a known infection. Standard precautions protect healthcare workers and patients from the spread of infections secondary to contaminated blood and other bodily fluids, using aseptic and sterile techniques. Asepsis prevents the spread of infection. The two types of asepsis are medical asepsis, or clean procedure, and surgical, or sterile asepsis. Medical asepsis reduces the number and growth of microorganisms, including pathogens. Medical asepsis includes things like hand washing, skin preparation prior to the injection of a subcutaneous medication, and the administration of all medications except those given intravenously. Surgical asepsis eliminates all microorganisms. Surgical asepsis is used for wound care during all invasive procedures, including surgical procedures and other invasive procedures such as endoscopy, for the administration of intravenous medications, and for the insertion of an indwelling urinary catheter and other internally placed tubes like central lines and peripheral intravenous lines. Using appropriate supplies to maintain asepsis. Sterile gloves are used for care that requires surgical asepsis. Clean gloves are used for care that requires medical asepsis. Masks and other supplies to protect the eye, nose, and mouth, like a HEPA mask and goggles, are used when droplets, sprays, and splashes of bodily fluids are possible. Lastly, sterile supplies and a sterile field are mandated for sterile procedures. Setting up a sterile field. These basic sterile asepsis procedures are followed for setting up and maintaining a sterile field. Sterile items only are placed on the sterile field. The nurse must never turn their back on the sterile field. The nurse must never lean over a sterile field. The nurse must never have the sterile field below waist level. Coughing or sneezing over the sterile field contaminates the sterile field. The nurse must maintain a 1-inch border around the sterile field that is not sterile. All sterile items and supplies are put inside of this 1-inch border. The sterile field must remain dry. Any wetness or moisture contaminates the sterile field. Sterile liquids must be poured carefully into sterile containers on the sterile field. Whenever these things are not done and maintained, the entire sterile field and its contents are discarded because the sterile field is no longer sterile. Using correct techniques to apply and remove gloves, masks, gowns, and protective eyewear. Using the correct technique to apply and remove gloves, masks, gowns, and protective eyewear are psychomotor skills that are best learned by viewing the procedures or studying pictures in a nursing textbook. So, during this discussion, we will only provide you with some basic principles for these techniques. We recommend that you review the psychomotor aspects of donning and removing personal protective equipment. Some basic principles for donning and removing personal protective equipment include donning sterile gowns and gloves using surgical technique by touching only the sterile surfaces of these items with sterile hands. For example, the first sterile glove is applied by touching the inside of the glove with a bare hand, after which the second sterile glove is donned by holding the glove with the sterile gloved hand without touching any skin surfaces. Another basic principle includes removing used personal protective equipment by folding the item inside out and disposing of it in the proper receptacle. Using correct hand hygiene techniques. Proper hand washing can be done with regular soap and water or a special antimicrobial soap. Hand washing is the best and most effective way to prevent the spread of infection when it is done correctly and properly. Hand washing is done using friction for a minimum of 20 seconds before and after each client contact, in addition to other times such as before and after donning and removing gloves. Alcohol-based hand cleansers are not a substitute for good hand washing. However, they can be used when running water and soap are not accessible. Alcohol-based hand washing products are liberally applied to the entire hand, after which the hands are rubbed until the entire hands are dried completely. Preventing the environmental spread of infectious disease through the correct use of equipment. Some supplies and equipment are disposable and for single patient use, and other supplies and equipment can be used among members of a group of patients. Single-use disposable supplies and equipment are never reused. They are discarded after the patient is discharged. When reusable supplies and equipment are used for more than one patient, the piece of equipment is disinfected after each patient use. Protecting the immunocompromised client from exposure to infectious diseases and organisms. Immunocompromised clients must be protected from exposure to infectious diseases and organisms because their body's protective natural immune system is not functioning correctly. In addition to standard precautions and proper hand washing, Other measures to protect immunosuppressed patients include protective precautions, which keep pathogens and other microorganisms away from the immunosuppressed patient that do not affect and infect other patients without immunocompromise. Monitoring the client care area for sources of infection. Throughout the delivery of patient care, nurses must constantly and continuously monitor and surveil the patient care environment for possible and likely sources of infection. Like all other safety concerns, nurses must report and correct all sources of infection in the patient care area. Reinforcing appropriate infection control procedures with clients and staff members. Nurses participate in identifying and correcting knowledge deficits relating to infection control policies and procedures among patients, family members, and staff members in the healthcare team. Health promotion and maintenance. The practical vocational nurse provides and directs nursing care of the client that incorporates knowledge of expected growth and development principles, prevention and/or early detection of health problems, and strategies to achieve optimal health. They should be able to provide care that meets the needs of the newborn less than 1 month old through the infant or toddler client through 2 years. Provide care that meets the needs of the preschool, school age, and adolescent client ages 3 through 17 years. Provide care that meets the needs of the adult client ages 18 through 64 years. Provide care that meets the needs of the adult client 65 through 85 years and over. Assist with fetal heart monitoring for the antepartum client. Assist with monitoring a client in labor. Monitor recovery of stable postpartum client. Collect data for health history. Collect baseline physical data, for example, skin integrity or height and weight. Recognize barriers to communication or learning. Compare client development to norms. Assist client with expected life transition, for example, attachment to newborn, parenting, or retirement. Provide care and resources for beginning of life and/or end of life issues and choices. Identify clients in need of immunizations, required and voluntary. Participate in health screening or health promotion programs. Provide information for prevention of high-risk behaviors or lifestyle choices. The aging process. Identifying the client's knowledge on the aging process and assisting in the reinforcement of teaching relating to the expected changes related to aging along the lifespan. Patients and family members must be informed about and knowledgeable about the aging process, the normal changes associated with aging, and ways to manage and cope with these normal changes. They must also be knowledgeable about what is normal and what is not normal. Now, I will discuss these changes related to the aging process system by system. Generally, all of these changes are decreases rather than increases of functioning. Sensory and neurological changes include decreased vision, hearing, smell, and touch, lowered reaction times, and night blindness. Cardiac changes include decreases in cardiac output, stroke volume, venous return, and the cardiac output. Musculoskeletal changes include decreased muscular tone and strength, the degeneration of joints and bones as the result of decalcification, and decreased intervertebral disc spaces which lead to some loss of height among the elderly. Renal function among the elderly is also affected with aging. Some of these changes include decreased renal size, decreased renal blood supply, decreased creatinine clearance, decreased glomerular functioning, and decreased tubular functioning. Liver function is a function also altered as a result of the normal aging process. There is decreased hepatic blood flow and functioning. This change reduces hepatic metabolism, and it can increase the concentrations of medications in the patient's body. Integumentary skin changes include the loss of skin turgor and elasticity, thinning and increased fragility of the skin, dry skin and hair, the presence of wrinkles, age spots and skin tags on the skin, faded and gray hair, thicker ear and nasal hair, thicker nails, and diminished sweat gland activity. Age-related respiratory changes include decreases in lung expansion and air exchanges, dry and more fragile mucous membranes, a diminished cough reflex, and a decrease in the efficiency of the body's natural protective immune system, which may place elders at greater risk for respiratory infections than their younger counterparts. Some fluid and electrolyte alterations associated with the aging process are imbalances secondary to the decreased function of those hormones that regulate fluids and electrolytes, impaired thirst sensation, more diluted urine, and changes in the amount of total body water and intracellular fluids. Medication dosages are often reduced for the elderly because the changes of the aging process make them at risk for more side effects, adverse drug reactions, and toxicity and overdoses. The distribution of drugs is impaired by decreases in the amount of body water, body fat, and serum albumin. Drug absorption is decreased with the aged patient's increases in gastric acid pH and decreases in the surface area of the small intestine, which absorbs medications and food nutrients. Providing care that meets the needs of the newborn less than 1 month old through the infant or toddler client through 2 years of age. From the day of conception throughout the entire lifespan, humans grow and develop in a rather predictable manner with specific needs from birth to the elderly years. Neonates are assessed according to the 5 criteria of the APGAR score. The criteria is A for appearance, P for pulse, G for grimace and reflexes, A for appearance in terms of skin color, and R for respiratory rate and effort. Each of these criteria is scored from 0 to 2 with a 0 as no activity or the poorest possible color, for example. APGAR scores are done 1 minute after birth, 5 minutes after birth, and more often when the neonate is not scoring well in terms of their adaptation to extrauterine life after birth. An APGAR score of less than 4 indicates that the neonate is in severe distress and in need of intensive care and treatment. An APGAR score of 4 to 6 indicates that the neonate is in moderate distress. Scores between 7 and 10 are considered good. Gestational age, which indicates the neonate's level of morbidity and mortality, is also determined and assessed among neonates. The new Ballard scale is used for this assessment. This scale measures physical and neuromuscular maturity from -1 to 5 according to the neonate's arm recoil, posture, heel to ear movement, the scarf sign, which is the neonate's crossing of the arms over the chest, and square window formation, which is the neonate's wrist movement. The normal physical size of a neonate is 18 to 22 inches in length, 12 to 13 inches for chest circumference, and 12.6 to 14.5 inches for the circumference of the head. The normal weight is from 5.8 to 8.13 pounds. The normal vital signs for the neonate are respirations from 30 to 60 per minute, the pulse from 100 to 160 beats per minute, a systolic blood pressure from 60 to 80 milliliters of mercury, a diastolic blood pressure from 40 to 50 milliliters of mercury, and a bodily temperature from 97.7 to 98.9 degrees. The normal neonatal abdomen is round. Bowel sounds should be present within a couple of hours after birth. The umbilical cord and site should be free of any signs of infection. The neonatal abdomen moves up and down with respirations. Neonates and infants are abdominal breathers. The eyes are bilaterally equal in terms of size and shape. The red and papillary reflexes are present, and normal smooth eye movement should be apparent. The neonate's ears should be normally placed with firm and well-formed cartilage. The ability to hear sounds and noise is normally present. Low-set ears and unusual eyes can indicate the presence of Down's syndrome. The skin of the neonate should be without any signs of blueness, jaundice, or cyanosis. The texture should be soft and smooth with some wrinkles. Vernix caseosa, a thick, cheesy substance, fine hair called lanugo, small red spots called malia, telangiectactic nevi, also referred to as stork bites, purple-blue Mongolian spots, and port wine stains called nevus flammeus are often seen on the skin. These unusual skin findings are most often temporary, with the exception of port wine stains, which can be permanent. The neonate's fontanelles are soft and flat and also without any sign of bulging, which can be a sign of increased intracranial pressure or depression, which can indicate increased intracranial pressure or dehydration respectively. These fontanelles close by the time the infant is 12 to 18 months of age. The sutures of the yet-to-be-developed skull are normally separated, and some normal molding of the skull can occur with a vaginal delivery. The oral palate is a closed palate. The mouth has pink oral mucosa, symmetrical lip and tongue movements, possible small white oral cysts called Epstein pearls on the tongue, and little saliva when the neonate's mouth is assessed. Down syndrome may be present when the tongue protrudes. A possible tracheoesophageal fistula is present when there is excessive saliva. Neonates normally pass meconium and produce urine at about 24 hours after birth. Male testes are in the testicles. The urinary meatus is on the tip of the penis, and the scrotum has rugae. The female may have some edema of the labium and a small amount of vaginal blood, both of which are normal for some neonates. Some passive immunity from the mother remains, but the infant does not have a fully developed immune system, so the infant is at risk for infections. As the neonate grows, they gain 5 to 7 ounces during the first 6 months and double their birth weight during the first year. The head circumference increases a ½ inch each month for 6 months and then 2/10 of an inch until the infant is 1 year of age. Similarly, the height or length increases an inch a month for the first 6 months and then 1/2 inch a month until the infant is 1 year of age. Teeth appear. The infant begins to speak with babble, and they start to walk in about 1 year. The infant is in the sensory motor stage according to Jean Piaget's stages of cognitive development and in Erik Erikson's the trust versus mistrust stage of psychosocial development. The infant begins to see self as separate from others, and separation anxiety and the fear of strangers, including nurses, begins. They communicate with noises and sounds, and they receive communication with touch. Age-appropriate toys include rattles, large balls, and teething toys. Commonly occurring injuries and accidents among infants include falls, poisoning, drowning, and burns. Aspiration and poisonings are great risks for infants because they are in the oral stage of development and they tend to put foreign bodies in the mouth. Infants are fed breast milk or formula every 2 to 4 hours with a total daily intake of 80 to 100 milliliters per kilogram of body weight. The toddler. The normal vital signs for the toddler are a pulse rate from 90 to 140 beats per minute. The normal respiratory rate for the toddler ranges from 20 to 40 breaths per minute. The diastolic blood pressure is typically between 50 and 80 milliliters of mercury, and the systolic blood pressure is from 80 to 110 milliliters of mercury. The normal bodily temperature is 98.6 degrees, and it remains at the level throughout the remainder of life. The toddler grows approximately 3 inches per year. The weight becomes 4 times the child's birth weight. Toilet training is completed during the toddler years, and the child walks without holding onto things by 15 months of age. They can jump by the time they are 2.5 years of age. Toddlers move from the Piaget's sensory motor stage to the pre-operational stage of cognitive development. The child's vocabulary improves, and the toddler can now speak in and communicate with brief but meaningful phrases. They understand parental boundaries and discipline. The toddler is in Erik Erikson's autonomy versus shame and doubt stage of psychosocial development, and the toddler begins to form their own gender identity. They are very curious and energetic. They lack impulse control. They have a short attention span. They are concrete rather than abstract thinkers, and they also are mystical thinkers. Toddlers also have a low tolerance for pain, frustration, and strangers. Nutritionally, toddlers eat 3 meals per day, totaling about 900 to 1,800 calories each day. Some are finicky eaters, and most enjoy finger foods that they can pick up, manipulate, and eat. Supplemental iron is needed for the adequate production of red blood cells. Large and colorful toys that cannot be placed in the mouth, picture books, and blocks are some examples of age-appropriate toys. Although toddlers play with other children and siblings, this play is parallel play rather than interactive play with other children. Toddlers are at risk for drowning, falls, aspiration, burns, automobile accidents, and suffocation. Providing care that meets the needs of the preschool, school age, and adolescent client ages 3 through 17 years of age. The preschool child. The normal vital signs for the preschool child are a pulse rate from 80 to 110 beats per minute. The normal respiratory rate for the preschool child ranges from 20 to 30 breaths per minute. The diastolic blood pressure is typically between 50 and 75 millimeters of mercury, and the systolic blood pressure is from 80 to 100 and 110 millimeters of mercury. The normal bodily temperature remains at 98.6 degrees. It remains at that level throughout the remainder of life. Physically, the preschool child gains about 4 to 7 pounds a year, and they grow 2 to 3 inches in height each year. Their gross and fine motor skills continue to be developed and enhanced. Preschool children have fears about the dark and mutilation. Separation anxiety decreases, and they are able to express their feelings and wishes to others verbally. They can follow brief, simple, and concrete directions from others, including the parents and healthcare providers. Preschool children should consume about 2,000 calories per day, and they are less prone to fluid and electrolytes than toddlers and infants. They often need between-meal snacks to satiate their hunger and meet their caloric needs. Commonly occurring injuries among the members of the age group are poisonings, drowning, burns, and automobile accidents. Preschool children begin to interactively play with others, and they ask a lot of why questions. Dress-up, role-playing, painting, puzzles, and reading simple books with lots of pictures are appropriate age-specific activities for the preschool child. Preschool children are in Piaget's stage of pre-operations, and they can speak in full sentences. In terms of Erik Erikson's psychosocial development stages, the preschool child is in the initiative versus guilt stage. Gender identity is complete, and gender-related activities increase. Some preschool children can understand simple explanations about the human body and illnesses. At times, the use of a simple picture, a puppet, and a simple picture book can assist with the child's understanding. The school-age child. The normal vital signs for the school-age child are a pulse rate from 70 to 100 beats per minute. The normal respiratory rate for the school-age child ranges from 20 to 25 breaths per minute. The diastolic blood pressure is typically between 55 and 80 millimeters of mercury, and the systolic blood pressure is from 80 to 120 millimeters of mercury. The school-age child's height, weight, and muscle mass increase with their growth spurts. These changes require additional calories of about 2,500 calories a day, additional calcium, additional iron, and additional vitamins, particularly vitamins B and A. The school-age child now prefers the same gender friends, and they may begin to question and challenge their parents and other authority figures, including their teachers and healthcare providers. Commonly occurring fears include fears of the unknown, bodily mutilation, fears associated with death, and the fear of failure. Physically, the school-age child gains about 4 to 9 pounds a year, and they go through growth spurts. Permanent teeth begin to appear. Secondary sex characteristics, puberty, and menarche can occur. Their stage of cognitive development is concrete operations and a full command of their native language. Vocabulary is almost complete by the age of 12. Erikson's stage of industry versus inferiority marks the school-age years. Peers become increasingly important, morals develop, and curiosity about sexuality occurs. Age-appropriate activities include sports, board and computer games, and pet care. Burns, automobile accidents, substance abuse, and drowning are the major accidents and concern among members of this age group. Adolescence. The normal vital signs for the adolescent are now the same as for the adult. Adolescents have high nutritional and caloric needs because of the growth spurt when the skeletal and muscular systems double to its completion. Vitamins, protein, and calcium needs have to be met. Females need iron supplementation because of menstruation. Some teens may develop bulimia and anorexia nervosa, both of which are eating disorders. Sexual maturity is complete. Most teens are attracted to the opposite gender. They are self-conscious. They want their own identity. They want to be accepted by their peer group, and they are sometimes unpredictable and rebellious towards authority figures. Adolescents complete the last of Piaget's stages, which is formal operations. They are in Erikson's identity versus role confusion stage, and they begin to think about and plan their future, including their career and advanced education beyond high school. Common threats, accidents, and injuries for this group are substance abuse, injuries from weapons, burns, auto accidents, sexually transmitted diseases, and unwanted pregnancy. Providing care that meets the needs of the adult client ages 18 through 64 years. The young adult. Normally, young adults form and maintain relationships, some of which are long-lasting and permanent. They assume adult roles as a spouse, parent, and salary earner with gainful employment. They also accept responsibility for their own beliefs, attitudes, opinions, values, and actions. Significant others include the spouse or partner, the children, friends, in-laws, and co-workers. Characteristic stressors for this age group include raising children, finding and maintaining a career, finances, and managing their multiple roles. Physical growth is complete. The young adult remains in the formal operations stage of Piaget, the last stage, and Erikson's intimacy versus isolation phase. Commonly occurring injuries and events include auto accidents, weapon injuries, substance abuse, and sexually transmitted diseases. Middle-age adults. The normal stages of the aging process begin during middle adult years. Muscular strength weakens, sex drive decreases, menopause and the male climacteric occur, and male erectile dysfunction may occur. Calcium and vitamin D supplementation are needed to prevent osteoporosis and bone loss that can occur as a result of menopause. Middle-aged adults are in Erikson's generativity versus stagnation stage. Major stressors include the loss of youth, parenting, and the empty nest syndrome. This group is referred to as the sandwich generation because members of this age group are often squeezed and conflicted with their care of children in addition to the care of their elderly parents. Health screenings for this group include eye examinations for glaucoma and DEXA screening for osteoporosis. Providing care that meets the needs of the adult clients ages 65 through 85 years and over. In terms of growth and development, this age group undergoes the normal changes of the aging process, including changes in terms of the sensory and neurological changes, cardiovascular changes, musculoskeletal changes, joints and bone changes, renal system changes, hepatic functioning changes, skin and hair changes, respiratory system changes, and fluid and electrolyte changes. All of these normal changes of the aging process were fully discussed previously with a section entitled The Aging Process. Adults 65 years of age and older are in the ego integrity versus despair phase according to Erikson. Caloric needs are less than other age groups. Some of the safety hazards affecting the aging population are falls and accidental poisonings. Antepartal, intrapartal, postpartum, and newborn care. The internal organs and structures of the female reproductive system are the uterus, uterine ligaments, vagina, fallopian tubes, ovaries, and the bony pelvis, which consists of two innominate bones, the sacrum and the coccyx. The external organs and structures of the female reproductive system are the mons pubis, urethral meatus, vaginal vestibule, labia minora, labia majora, clitoris, and the perineal body. Identifying the physical changes of pregnancy. Some of the physical changes that occur during pregnancy include the presumptive, probable, and positive signs of pregnancy, urinary system changes, circulatory system changes, endocrine system changes, gastrointestinal system changes, skin changes, respiratory system changes, skeletal changes, central nervous system changes, metabolic changes, and vital sign changes. The presumptive signs of pregnancy are urinary frequency, fatigue, amenorrhea, nausea and vomiting, which is referred to as morning sickness, breast soreness, darkened areola, large Montgomery glands, uterine enlargement, vaginal discoloration, skin pigment changes, and fetal movement, which is also referred to as quickening. The probable signs of pregnancy include Hegar's sign, which is changes to the lower portion of the uterus, abdominal enlargement. A positive human chorionic gonadotropin or HCG test, Braxton-Hicks contractions, Chadwick's sign, which is a blue tinge to the vagina and cervix, Goodell's sign, which is the softening of the cervix, the ability to palpate the fetus, which is referred to as fetal ballottement, and cervical and uterine changes in terms of consistency, size, and shape. And lastly, the positive signs and symptoms of pregnancy are fetal heart tones, ultrasound evidence of a fetus, and the objective assessment of fetal movement. Identifying the client's emotional preparedness for pregnancy. Nurses identify the client's emotional as well as physical responses to the preparedness for pregnancy. Many emotions and different perceptions can occur as a response to pregnancy. Some of these emotions include joy, fear, mood swings, anxiety, financial concerns, depression, and adverse emotional reactions to the bodily changes of pregnancy. The father may also have similar reactions. Some women may have a lot of social supports during this maturational milestone in terms of family members and their spouse or partner. Others may have little or no support. This is particularly true when the partner is absent and/or not welcoming of an unwanted pregnancy. Pregnancy leads to emotional disequilibrium for the pregnant woman and the family unit. Nurses must facilitate effective and successful coping to meet the emotional needs of the woman and the family unit, and also the utilization of available social supports and resources. Assisting in performing a client's non-stress test. Non-invasive non-stress tests to determine the status of a fetus are routinely done during the last trimester of pregnancy. A non-stress test is particularly important when increased maternal age, hypertension, diabetes, post-maturity, intrauterine growth restrictions, abnormal fetal movements, sickle cell disease, and/or a history of previous obstetrical complications are present. A non-stress test is performed by placing a transducer on the pregnant female's abdomen, which is attached to a Doppler. This test measures the fetal heart rate during movements of the fetus, the functioning of the fetus's central nervous system, and their overall well-being. An abnormal non-stress test occurs when the fetus's heart rate does not increase by at least 15 beats per minute for at least 15 seconds during fetal movements. A normal reactive non-stress test occurs when the fetus reacts to movement with a heart rate increase of 15 beats per minute or more for at least 15 seconds when fetal movement occurs and on at least 2 occasions during this non-stress test. Assisting with fetal heart monitoring for the antepartum client. Now, we will discuss monitoring the fetal heart rate during the antepartum period of time. Some of the terms used in respect to fetal heart rate monitoring will be defined now. The baseline fetal heart rate is the average fetal heart rate per minute during a 10-minute period of time without any periods of significant variability or any period when the rate varies by more than 25 beats per minute. A wandering baseline fetal heart rate is a fluctuating fetal heart rate from the baseline. This abnormal fetal heart rate pattern can indicate disorders like a congenital abnormality or metabolic acidosis. An acceleration is defined as an increased fetal heart rate over the fetal heart rate baseline with a less than 30-second duration from the onset to the peak. Accelerations can be prolonged, episodic, or periodic. A prolonged acceleration is an acceleration of the fetal heart rate that lasts more than 2 minutes. An episodic acceleration is defined as an assuring fetal heart rate pattern that normally occurs with fetal movements. Periodic acceleration is an acceleration that occurs with contractions. They are normal. A deceleration is a fetal heart rate that is less than the baseline. Decelerations can be early, late, variable, or prolonged. The onset of deceleration is the point where the fetal heart rate falls below the baseline. The nadir of deceleration is the lowest point of the deceleration. The descent of deceleration is the time between the onset and the nadir of deceleration. The depth of deceleration is the number of beats per minute that occur during a deceleration until it reaches its nadir. The duration of a deceleration is the time elapsed from the onset of the deceleration to the fetus's baseline fetal heart rate. The recovery of the deceleration is the time elapsed from nadir to the fetus's baseline fetal heart rate. A late deceleration is a gradual decrease of the fetal heart rate below baseline during contraction. An early deceleration is a gradual increase of the fetal heart rate below the baseline during contraction, which occurs during the peak of the contraction. Variable decelerations occur when the fetal heart rate suddenly decreases by at least 15 beats per minute that lasts at least 15 seconds before it returns to the baseline. A prolonged deceleration is defined as a decrease in the fetal heart rate of 15 or more beats per minute that persists more than 2 minutes from its onset to its return to the baseline. Variability is classified as with minimal variation when it varies by less than 5 beats per minute. Moderate variability occurs when fetal heart rate varies by 6 to 25 beats per minute. And marked and severe variability occurs when the fetal heart rate varies by more than 25 beats per minute. Non-reassuring fetal heart rates and heart rate patterns include the absence of any variability, late decelerations, variable decelerations, fetal trachycardia, and fetal bradycardia. Non-invasive fetal heart rates are monitored on a continuous or in an intermittent basis. The necessity of fetal heart monitoring is underscored when the mother has complications such as abnormal uterine contractions, hypertension, diabetes, a post-term pregnancy, renal disease, and/or the fetus is at risk as the result of one or more factors such as fetal distress, meconium-stained amniotic fluid, multiple gestations, placenta previa, abruptio placentae, an abnormal contraction stress test, an abnormal non-stress test, bradycardia, and intrauterine growth restriction. Non-invasive external fetal monitoring is advantageous over invasive internal fetal heart monitoring because there is less risk of infection, there is no need for the rupture of the membranes or the dilation of the cervix at 2 or more centimeters, and there is no need for the fetus to have a descended presenting part. Invasive internal fetal monitoring, when compared and contrasted to external fetal monitoring, is advantageous because it provides a higher quality and more accurate reading that is also not impaired with factors such as maternal obesity, fetal positioning, and maternal positioning. Normally, fetal heart rate baselines are from 110 to 160 beats per minute, excluding any decelerations, accelerations, or episodes of variability over a 10-minute period of time. Assisting with the monitoring of a client in labor. Labor is the natural process or induced process that consists of involuntary rhythmic uterine contractions that increase in terms of frequency and intensity. Labor leads to the necessary effacement and dilation of the cervix that is needed for the vaginal delivery of the baby after pregnancy. Effacement is the thinning and shortening of the cervix. Dilation is the opening of the cervix. Labor usually begins about 2 weeks prior to the expected delivery date. Labor usually lasts from 12 to 18 hours. The stages of labor and delivery include the first, second, third, and fourth stages of labor. The first stage of labor consists of the latent, active, and transition phases. The latent phase typically lasts for several hours, and the contractions are mild. During the active phase, the contractions become more frequent and severe. The cervix dilates up to 7 centimeters, and the fetus begins to descend in the birth canal. The transition phase of the first stage of labor is characterized with the increased frequency, intensity, and duration of the contractions. The cervix dilates up to 10 centimeters. The second stage of labor begins when the cervix is dilated 10 centimeters, and it ends with the birth of the infant. The third stage of labor begins with the vaginal delivery of the baby and ends with the products of conception, that is, the placenta, are expelled. The fourth stage occurs during the first several hours after delivery. During the latent phase of the first stage of labor, the mother should be encouraged to rest, walk, perform relaxation techniques, and take deep breaths. Food and fluids are limited and restricted during this phase of the first stage of labor. They should also be encouraged to urinate every hour. During the active phase of the first stage of labor, the client should be encouraged to continue voiding every hour and also to continue with ambulation, rest, and relaxation exercises. At times, such as with prolonged labor, intravenous fluids may be used to prevent and treat dehydration. Nurses promote comfort and provide basic nursing care with things like massages, oral care, and frequent positioning for comfort. The spouse or significant other should also be encouraged to care for their partner during this and all other stages of labor. Contractions and maternal vital signs are checked and monitored every 15 minutes, and the fetal heart rate is also monitored at least every 15 minutes. Fetal assessments include assessing and monitoring the fetal heart rate at least every 15 minutes, as well as much more often and even continuously when the fetus is at risk. The mother must be reminded to pant rather than push in spite of the fact that the woman in labor has a strong urge to push. Maternal and fetal monitoring and assessments continue every 15 minutes as well, and much more often and even continuously when the fetus is at risk. The fetal lie, presentation, attitude, station, and position are also monitored and assessed during labor. Fetal lie is defined as the relationship of the fetus's spine to the mother's spine. Fetal lie can be a longitudinal, transverse, or oblique lie. Longitudinal lie, the most common and normal lie, occurs when the fetus's spine is aligned with the mother's spine in an up and down manner. A transverse lie occurs when the fetus's spine is at a right 90-degree angle with the maternal spine. Lastly, an oblique lie occurs when the fetus's spine is diagonal to the mother's spine. Fetal presentation is defined by what the fetus's presenting part is in the birth canal during labor. The possible fetal presentations are the cephalic presentation, the cephalic vertex presentation, the cephalic sinciput presentation, the cephalic face presentation, the cephalic brow presentation, the breech presentation, the complete breech presentation, the frank breech presentation, the shoulder breech presentation, and the footling presentation. The cephalic head presentation, the most common and normal presentation, is the head as the presenting part. The cephalic presentation can be further classified and categorized as the cephalic vertex presentation, where the fetus's head is on its chest, the cephalic sinciput presentation, where the head is partly flexed, the cephalic face presentation, where the face is the presenting part of the head because the fetus's head is hyperextended, and the cephalic brow presentation, which occurs when the fetus's head is extended. A breech presentation occurs when a fetal body part, other than the head, is the presenting part. The breech presentation can be further classified and categorized as the complete breech presentation, when the fetus's buttocks are the presenting part, the frank breech presentation, that occurs when the buttocks are present and the legs are straight up, the shoulder breech presentation, when the shoulder presents, and the footling presentation, where one or both of the feet presents. Fetal attitude is the positioning of the fetus's body parts in relationship to each other. The normal attitude is general flexion in the fetal position. All attitudes other than the normal attitude can lead to a more intense and prolonged labor. Fetal station is the level of the fetus's presenting part in relationship to the mother's ischial spines. Fetal station is measured in terms of the number of centimeters above or below the mother's ischial spines. Fetal station is -1 to -5 when the fetus is 1 to 5 centimeters above the ischial spines. It is from +1 to +5 when the fetus is 1 to 5 centimeters below the level of the maternal ischial spines. Fetal position, simply stated, is the relationship of the fetus's presenting part to the anterior, posterior, right or left side of the mother's pelvis. The relationship of the fetus's presenting body part, such as left anterior, left posterior, right posterior, and right anterior, in relationship to the maternal pelvis, which is called the anterior, posterior, right and left pelvis, which are noted and documented as A, P, R, or L. The presenting part of the fetus is referred to as mentum, occiput, sacrum, and acromion. The presenting parts are noted and documented as M, O, S, and A, respectively. The only normal positions are the left and right occiput anterior fetal position, which is the ROA and ROL, respectively. Face presentation positions are noted and documented as RMA, for right mentum anterior position, RMT for the right mentum transverse position, RMP for the right mentum posterior position, LMA for the left mentum anterior position, LMT for the left mentum transverse position, and LMP for the left mentum posterior position. Vertex presentation positions are noted and documented as ROA for the right occiput anterior position, ROT for the right occiput transverse position, ROP for the right occiput posterior position, LOA for the left occiput anterior position, LOT for the left occiput transverse position, and LOP for the left occiput posterior position. Breech presentation positions are noted and documented as RSA for the right sacrum anterior position, RST for the right sacrum transverse position, RSP for the right sacrum posterior position, LSA for the left sacrum anterior position, LST for the left sacrum transverse position, and LSP for the left sacrum posterior position. Acromion presentation positions are noted and documented as RAA for the right acromion anterior position, RAT for the right acromion transverse position, RAP for the right acromion posterior position, LAA for the left acromion anterior position, LAT for the left acromion transverse position, and LAP for the left acromion posterior position. There are several types of delivery, including vaginal deliveries, operative deliveries such as a forceps delivery, a vacuum delivery, and a cesarean, and a vaginal birth after a cesarean section. Vaginal deliveries are the most common form of delivery. Vaginal deliveries can be done with or without an episiotomy. An episiotomy may be indicated when the baby is excessively large, when there is shoulder dystocia, and/or maternal or fetal stress is present. Forceps facilitate the delivery of the baby by providing traction. They can also facilitate the rotation of the fetus's head to the vertex position. All forceps, except Piper forceps, are applied to the sides of the head and only when the fetus's presentation is presenting downward. Piper forceps are used for breech presentations after the fetus's head is reachable after the delivery of the rest of the body. The complications of forceps deliveries include maternal trauma, lacerations, pelvic floor damage, bleeding, and an inadvertent extension of the episiotomy to the anus. Neonate complications include a low APGAR score, neurological trauma and damage, a fractured clavicle, and Erb's palsy. Vacuum deliveries are done with the application of suction to the occipital part of the fetal head to assist in the delivery when the second stage of labor is extensively long and/or there is a non-reassuring fetal heart rate pattern. Attempted vacuum deliveries are ceased when there is no success after about 1/2 hour. Cesarean births are indicated with placenta abruptio, placental previa, cephalopelvic disproportion, a non-reassuring fetal heart pattern, and a cord prolapse. The incision can be a skin incision, which can be vertical or transverse, and a uterine incision, which is done into the uterus. Some of the maternal complications associated with cesarean births are infection, hemorrhage, shock, emboli, and adverse reactions to anesthetic agents. Trial labor and a vaginal delivery can be attempted after the mother has had a cesarean section in the past, except under some circumstances, such as an inadequate pelvis. Performing the care of postpartum client. Postpartum maternal physical care can be remembered with the word bubble. The B of bubble is the breasts. The U of bubble is the uterine fundus height, consistency, and placement. The B of bubble is the bowel and other gastrointestinal functioning. The second B of bubble is bladder functioning. The L of bubble is lochia amount, consistency, color, and odor, and the E of bubble is episiotomy, edema, and redness. Vaginal discharge progresses from bloody vaginal drainage with some small clots for about 10 days, after which the vaginal drainage is brown and may continue for up to about 6 weeks. All the vital signs should return to their normal levels in 24 hours after delivery. Mothers, particularly new mothers and significant others, need some assistance and support in terms of newborn care and infant feeding. They must know the nutritional needs of the baby, how to breastfeed or bottle feed, how to provide cord care and circumcision care, diapering, bonding, attachment, preventing accidents such as placing the infant on their back to prevent suffocation, and how to respond to the baby's crying. The nutritional needs of the neonate include about 110 kcals per kilogram a day for the first 3 months of life, and then 100 kcals per kilogram a day until the infant is 6 months of age. Neonates and infants also need 2¼ to 4 grams of protein each day, and 140 to 160 milliliters of fluid per day. Human milk is the best form of nutrition for babies up to at least 6 months of age. It is more readily and easily absorbed and digested than formula milk. A healthy diet for the lactating breastfeeding mother should include small amounts of fats, protein, whole grains, dairy products, fresh fruits, and vegetables. Special foods are not needed to produce milk or to maintain an ample milk supply. The normal breastfeeding process includes the proper positioning of the infant and mother, latch-on, and the sucking and swallowing sequence. Positioning and holding the neonate for breastfeeding will become a personal preference. However, there are a number of positions that the mother should be instructed about, including the football clutch hold position, the cradle position, the modified cradle position, and the side lying position. Latch-on is placing the areola and a large portion of the breast into the baby's mouth. The infant's rooting reflex promotes their latching on. It can be stimulated by stroking the baby's cheek when the nipple is in the baby's mouth. The suck and swallow sequence starts when the infant starts to suck. The milk is then moved with the infant's tongue to the back of the mouth, and then the infant swallows. Mothers who choose to bottle feed should be instructed about the safe and proper way to feed their infant. They should be instructed to hold the baby and not prop the bottle up for automatic feeding. Contributing to the newborn's plan of care. Licensed practical nurses monitor the newborn's physical and emotional status, the mother's physical and emotional status, the maternal and parental bonding, and attachment to the neonate. The results of this monitoring is documented and shared with the supervising registered nurse, who will incorporate these findings into the newborn's plan of care. Reinforcing client teaching on infant care skills. Client teaching is reinforced when a knowledge or skill deficit is noticed. Reinforcement of teaching often revolves around the feeding, bathing, and positioning of the newborn. Monitoring the recovery of a stable postpartum client. As discussed above, the mother is monitored during the postpartum period of time using BUBBLE and other physical criteria, such as vital signs. Monitoring the client's ability to care for the infant. Again, new mothers are monitored in terms of their abilities to provide care to the infant. Teaching and the reinforcement of teaching are necessary when a learning need is discovered. The essentials of newborn care include bathing, feeding, quieting strategies, swaddling, diapering, cord care, and circumcision care. Data collection techniques. The purpose of the health history is to collect data and information about the patient's and family's current and past states of health, their risks, their strengths, weaknesses, and their needs. Collecting data for the health history. This data can be primary or secondary data. It can be subjective or objective. It can be quantitative or qualitative. An example of primary data is information that you get directly from the patient. Secondary data is information that you collect from sources other than the patient, such as progress notes from the patient's last acute care hospitalization. Objective data is measurable and observable, like a patient's blood glucose level that you can see on a blood glucose monitoring machine. Subjective data consists of the patient's own words, such as, "I am in pain." Quantitative data is numerical data, like laboratory results. Qualitative data is narrative information, like the patient's description of the pain in terms of its location. Data and information is collected using the interview process. Two kinds of questions are used during the interview to collect data. These questions are open-ended and close-ended questions. Close-ended questions are answered with a simple no or yes answer. An example of a closed-ended question is, "Are you married?" The answer will be yes or no. On the other hand, an open-ended question gets more data and information than a simple yes or no. An example of an open-ended question is, Tell me about what you were doing when your pain started. Open-ended questions give us fuller and deeper data and information than closed-ended questions. A complete health history consists of demographic data, the patient's chief complaint, the patient's past medical history, the family's current and past medical history, lifestyle choices, the patient's utilization of and access to healthcare services, medication reconciliation, other data such as spiritual, religious beliefs, and cultural background. Some demographic data and information that is collected during the health history are the patient's name, address, contact information, health insurance information, age, marital status, and occupation. Nurses collect data and information about the patient's chief complaint by asking an open-ended question, such as, "Why did you come to the emergency room today?" The patient will likely respond to this question with data and information about their chief complaint. Data included with past medical history includes immunizations, prior surgeries, previous hospitalizations, any healthcare adverse events like a latex reaction or a reaction to anesthesia, allergies, chronic illnesses, and the current medications, supplements, and over-the-counter preparations that they are currently taking. The current medical history is a further exploration of the patient's chief complaint in terms of the patient's symptoms, when the symptoms began, things that make the symptoms worse, things that precipitate the symptoms, things that decrease the severity of the symptoms, the location of the symptoms, and how often the symptoms occur. During the family history phase of the health history, the nurse collects data and information about relatives' health histories, including the presence of any heart disease, psychological and social disorders, genetic disorders, hypertension, cancer, diabetes, the ages, current states of health, or age and cause of death for grandparents, parents, siblings, and children. Additional data and information about lifestyle choices are collected to determine risks and risk factors. Lifestyle choices include choices relating to the diet, activities of daily living, consumption patterns relating to drugs, alcohol, and caffeine, exercise, sleep and rest patterns, and occupational choices. The patient's patterns of healthcare are determined in terms of what type of healthcare resources they utilize and whether or not these resources and services are accessible to them. Other data and information that is collected includes psychological, emotional data, cultural data, functional abilities information, spiritual or religious data, advanced directive information, any healthcare surrogate or proxy, and a medication reconciliation and medication history. Some of the psychological data collected include things like the parent's stressors, coping mechanisms, mood, affect, thought processes, and any history of an acute or chronic psychological disorder or abuse and neglect. Some of the cultural data that is collected include the person's ethnic and cultural customs, beliefs, practices, and preferences. Religious and spiritual data includes customs, beliefs, practices, and preferences. Developmental stages and developmental tasks, as previously discussed, are determined, and these findings are then compared to the expected level of development. Some of the functional data that is collected relates to the patient's biological, psychological, and social status, and how these factors impact on the patient's ability and motivation to perform their activities of daily living. Standardized tests of functional ability, such as the Barthel Index, the Klein-Bell Scale, the Assessment of Motor and Process Skills Test, the Functional Independence Measure, and the Get Up and Go test, can also be used. Social data includes support systems, the family unit, economic status, level of education, and employment. Collecting baseline physical data. Baseline data that is collected after the health history and before the complete head-to-toe examination includes the patient's weight, height, body build, posture, gait, obvious signs of distress, level of hygiene and grooming, skin integrity, and the patient's actual age compared and contrasted to the age that the patient actually appears like. For example, does the patient appear to be older than their actual age? Does the patient appear to be younger than their actual age? Preparing the client for physical examination. Nurses prepare and position clients for physical examinations. Nurses provide privacy, explain and reinforce the procedures to the client, and ensure that the client is as comfortable as possible during the physical examination. documenting findings according to agency facility policies and procedures. As with all other aspects of nursing care, all data and information that is collected with the health history and the physical examination is documented according to the particular facility's policies and procedures. Some facilities use special forms for this data and information. Reporting client physical examination results to the healthcare provider. Registered nurses, advanced practice nurses, such as nurse practitioners, and doctors typically do the complete head-to-toe physical assessment and examination and document all of those details in the patient's medical record. However, licensed practical nurses review these details and compare this baseline physical examination data and information to the current patient status as they are providing ongoing care. They also report and document all their significant physical examination results to the supervising registered nurse and/or the patient's healthcare provider. The 4 basic methods or techniques that are used for physical assessment are inspection, palpation, percussion, and osculation. Inspection is the visual examination of the patient. Palpation is done when the person doing the assessment places their fingers on the body to determine things like swelling, masses, and areas of pain. Percussion is tapping the patient's bodily surfaces and hearing the resulting sounds to determine the presence of things like air and solid masses affecting internal organs. The sounds that are heard with percussion are resonance, which is a hollow sound, flatness, which is typically heard over solid things like bone, hyperresonance, which is a loud booming sound, and tympany, which is a drum-type sound. A thorough physical assessment consists of the general survey, vital signs, the assessment of the thorax and lungs, including lung sounds, the assessment of the cardiovascular system, including heart sounds, the assessment of the head, the assessment of the neck, oxygen saturation, the integumentary system assessment, the assessment of the peripheral vascular system, the assessment of the breast and axillae, the assessment of the abdomen, the assessment of the musculoskeletal system, the assessment of the neurological system including all the reflexes, the assessment of the male and female genitalia and inguinal lymph nodes, and the assessment of the rectum and anus. Developmental stages and transitions. This section will provide you with the expected stages of growth and development for all age groups, and how to modify and adjust approaches to care as based on these stages. The age groups along the lifespan and their age parameters are the neonate, which is the first 4 weeks of life, the infant, who is from 4 weeks old to 1 year old, the toddler, who is from 1 to 3 years of age, the preschool child, who is from 3 to 5 years of age, the school-age child, who is from 6 to 12 years of age, the adolescent, who ranges from 13 to 17 years of age, the young adult, who is from 18 to 25 years of age, the adult, who is defined as from 26 to 65 years of age, and lastly, the older adult, who is over 65 years of age. Age and developmental stages are assessed not only to determine if the client is at the expected level of development, but also to modify all aspects of care and communication according to the client's specific needs. Erik Erikson's developmental tasks and Piaget's stages of cognitive development were previously discussed for each of the age groups under the topic aging. The 5 stages of Sigmund Freud's stages of psychological development are the oral stage, the anal stage, the phallic stage, the latency stage, and the genital stage. Other developmental theories include those of Robert Havighurst, Stella Chess and Alexander Thomas, Roger Gould, Lev Vygotsky, and Robert Peck. Identifying and reporting client deviations from expected growth and development. As with all other nursing care, nurses must be able to identify and report client deviations from what is expected in terms of their growth and development. They must also be able to modify care and their approaches to care as based on these deviations. Identifying the occurrence of expected body image changes. The major expected bodily changes and bodily image changes are those that occur with puberty, menopause, pregnancy, and the aging process. Recognizing barriers to communication and learning. As fully discussed previously with the integrated processes of communication and documentation and teaching and learning, there are barriers that have to be overcome in terms of communication and learning. Comparing client development to norms. As discussed just now, nurses must be able to identify and report client deviations from what is expected in terms of their growth and development, and they must also be able to modify care and their approaches to care as based on these deviations. Assisting the client with expected life transitions. Some expected life transitions along the lifespan include transitions in terms of puberty, pregnancy, parenting, and retirement. All life transitions disrupt the patient's and significant other's physical and psychological balance and homeostasis. Nurses assist and support their patients during these expected life transitions. For example, the nurse may teach a parent about puberty. The nurse supports pregnant women and significant others throughout the intrapartal period as previously discussed. They promote and encourage bonding, attachment, and good parenting skills. Nurses also support and assist older patients who are affected with retirement and other stressors, such as the empty nest syndrome. Assisting the client to select age-appropriate activities. Communication, teaching, and the provision of leisure activities for adults and play activities for children of all ages were also previously discussed. For example, neonates and infants receive communication with the touch or coo of an adult. They enjoy colorful things like a mobile. Infants and toddlers must not be given any small toys or toys that can disassemble into small parts because they are in the oral stage of development. This means they place objects in the mouth, which places them at risk for aspiration and death. Adolescents are rebellious. They want to be with and accepted by their peers. Adults enjoy socialization and activities like different sports and an exercise regimen. Older adults may be in need of activities such as those in an elder daycare center and reminiscence therapy. Modifying approaches to care in accordance with the client's developmental stage. Patient care and approaches to patient care are modified and changed in accordance with the client's developmental stage. Providing care and resources for the beginning of life and the end of life issues and choices. The care of the neonate and infant and care at the end of life and its choices were previously discussed with the topic ante, intra, postpartum, and newborn care, monitoring clients' abilities to care for the infant, and advanced directives, respectively. Determining the client's acceptance of expected body image changes. Because many clients are affected by some expected life transitions along the lifespan like puberty, pregnancy, parenting, and retirement, nurses must identify and determine the patient's responses to and acceptance of these life transitions. All maladaptation and/or poor coping skills must be determined, documented, and reported so that the patient's plan of care can be changed to meet these needs. Determining the impact of expected body image changes on the client. Nurses also determine the impact of expected body image changes on the client in terms of how the patient's perceptions are interfering with the patient's quality of life and the continued performance of their activities of daily living. Again, all maladaptation and/or poor coping skills must be determined, documented, and reported so that the patient's plan of care can be changed to meet those needs. Health promotion and disease prevention. Identifying risk factors for diseases, illnesses. Simply defined, a risk factor is an intrinsic or extrinsic factor or force that could lead to an illness, infection, disease, or disorder. An example of an intrinsic risk factor is the presence of hypertension, which places the patient at risk for other disorders. An example of an extrinsic risk factor is contaminated food, which places the person at risk for foodborne illnesses or infections. Some risk factors can be decreased or eliminated, and other risk factors cannot be changed or eliminated. For example, genetics, age, and gender cannot be changed. However, things like poor dietary and consumption patterns can be eliminated. Data and information about the patient's risk factors are collected during the admission health history, during the physical examination, and throughout the course of care. Identifying clients in need of immunizations. Immunizations can be mandatory and required, and others can be voluntary. Childhood immunizations against communicable diseases are often required according to the CDC and state laws. Adult immunizations against pneumonia may be recommended by the CDC, but it remains voluntary. Nurses must be aware of the recommendations and mandates for immunizations as based on the age group that they are caring for. For example, the nurse must be aware of the CDC's scheduled childhood immunizations when they are working with pediatric patients. They must be aware of the CDC's adult recommended vaccination when they are caring for adult patients at risk. For example, the nurse caring for adult patients must be aware of recommended immunizations when the patient is elderly and when they have a history of respiratory disease. Both the elderly patient and the adult patient with respiratory diseases, for example, should get the pneumonia vaccine and an annual influenza vaccine. Identifying precautions and contraindications to immunizations. Old wives' tales and myths revolve around immunizations and contraindications to them. These knowledge deficits have to be addressed because they not only can adversely affect the patient's health, but they can also adversely affect public health and global health. One example of misinformation is the belief by many that vaccinations lead to autism, despite the fact that there is no scientific evidence to support this misinformation. Vaccinations do not lead to autism. Some also believe that a child should not be vaccinated when they have a fever or a respiratory infection. This also is not true. Despite these old wives' tales and myths, the CDC does have some contraindications and precautions to specific immunizations. For example, second doses of an immunization to the hepatitis vaccine and the DTaP are contraindicated when the person has had anaphylaxis after the first dose. These same vaccinations have precautions when the person has severe acute illness with or without a fever. Identifying the client's health-seeking behaviors. Nurses observe and identify patients' health-seeking behaviors that promote health and wellness. These behaviors can be identified in a number of ways, including when the patient or significant other asks the nurse for suggestions in terms of a healthier diet or an exercise routine, and when the nurse identifies the fact that they are keeping scheduled doctor's appointments and/or they are performing monthly breast or testicular self-examinations and staying current with the age and risk-related screening tests and examinations. Gathering data on the client's health history and risk for disease. Nurses collect data relating to the client's risk for disease during the health history, as mentioned above. Again, some of these risk factors are modifiable and others are not. Checking the results of client health screening tests. Nurses check and follow up on client screening tests, such as stool for occult blood, a Papa-Nicolau Pap test, and a colonoscopy screening test. Results are also reported to the patient's doctor and entered into the patient's medical record, according to the facility's specific policies and procedures. Providing assistance for screening examinations. Nurses instruct, prepare, and assist clients for screening examinations that can identify diseases in its earliest stages. The U.S. Preventative Services Task Force and other organizations provide screening guidelines and schedules similar to those that the CDC does for immunizations. Many are based on the patient's age because the different age groups are at higher risk for diseases and disorders than other age groups. Some of the U.S. Preventative Services Task Force's recommended screening tests are tests for diabetes, breast cancer, cervical cancer, prostate cancer, colorectal cancer, osteoporosis, scoliosis among school-age children, hepatitis B and C, human immunodeficiency virus, hypertension, hyperlipidemia, glaucoma, hearing, obesity, and depression. Participating in health screening and health promotion programs. At times, nurses may be asked and assigned to participate in health screening and health promotion programs. They may perform health screening tests, and they may also be asked to instruct a group of participants about healthy diets. Assisting clients with disease prevention activities. Similar to the nurse's participation in health screening and health promotion programs, nurses often assist, instruct, and coach clients with disease prevention activities such as an exercise routine and other lifestyle changes that prevent disease. Monitoring client actions to maintain health and prevent disease. Nurses and other healthcare providers monitor the client's actions that aim to maintain health and prevent illness. Some of the patient actions that nurses monitor include monitoring compliance with screening and immunization recommendations and schedules, the patient's efforts to limit and eliminate risks, such as those that occur with smoking cessation, the use of relaxation and stress management techniques to control hypertension, the consistent commitment to a healthy diet, and daily exercise to control obesity. Monitoring the incorporation of healthy behaviors into one's lifestyle by the client. Healthy changes and some of the healthy behaviors that nurses can monitor include determining whether or not the patient is adhering to immunization and screening recommendations, determining whether or not the patient is eating a healthy diet, and determining whether or not the patient is eliminating all high-risk taking behaviors, such as illicit drug use, for example. Reinforcing teaching with the client about health risks and health promotion. Nurses not only provide initial teaching to patients and significant others, they also reinforce teaching when the need to do so arises. All the necessary knowledge, skills, and abilities needed in respect to health risks and health promotion are forgotten over time. Recognizing a client's unexpected responses to immunization. Reactions to vaccinations may occur. The most commonly encountered unexpected responses and side effects to immunizations are minor and typically harmless ones that can include redness at the site and swelling at the site. A severe allergic anaphylactic reaction is also possible, but it is rare. Nonetheless, when anaphylaxis does occur, it usually happens 15 to 20 minutes after the injection. So, for this reason, nurses should monitor the patient for this serious and life-threatening reaction for at least 20 minutes. Assisting the client to identify high-risk behaviors. Some patients are fully aware of and knowledgeable about high-risk behaviors and others are not. Nurses must identify this knowledge deficit and instruct the patient about risk factors and high-risk behaviors that they may not be aware of. For example, some patients may have the need to learn about the risks associated with illicit drug use and unprotected sex. Other patients may have the need to be enlightened about the fact that excessive exposures to the sun can lead to skin cancer. Providing information for prevention of high-risk behaviors or lifestyle choices. After the patient is informed about high-risk behaviors, the nurse assists the patient by providing written and oral information so that they are better able to decrease and eliminate high-risk behaviors and poor lifestyle choices. For example, a patient who has a high cholesterol level may need information about foods that are high and low in cholesterol so they can adjust their diet. Monitoring the client's lifestyle practice risks that may impact health. A change in the patient's behavior should occur when the patient is knowledgeable about high-risk behaviors and poor lifestyle choices and specific ways that these risks can be decreased and eliminated. Because the goal of this education is to change behaviors, nurses should monitor patients over time to determine if their practices, such as an avoidance of sun and daily exercise, have been maintained and sustained. Reinforcing teaching related to high-risk behaviors and lifestyle choices. Nurses not only provide initial teaching to patients and significant others, they also reinforce teaching when the need to do so arises. All the necessary knowledge, skills, and abilities needed in respect to high-risk behaviors and poor lifestyle choices may be forgotten over time, so this information must be reinforced as often as necessary. Lifestyle choices. Identifying client lifestyle practices that impact on health. The lifestyle choices that impact on health include choices about exercise, diet, the patient's use of stress management techniques, sexual practices, and consumption patterns relating to smoking, illicit drug use, and alcohol consumption. Nurses collect data and information about these lifestyle choices, after which this data and information is used to identify the patient's needs that will be incorporated into the patient's plan of care. Identifying contraindications to contraceptive methods. A multitude of contraception methods are available. Individuals typically choose among different methods that are not contraindicated for them and then decide on what is best for the couple in terms of cost, effectiveness, and related issues such as convenience. Some forms of contraception are contraindicated for some medical conditions and lifestyle choices. For example, Women who have a history of deep vein thrombosis and who are cigarette smokers cannot use oral contraceptives because they are at risk for clots and strokes when this method of contraception is used. Identifying client attitudes, perceptions on sexuality. Attitudes and perceptions relating to sexuality vary among individual patients and also among those with a particular culture and/or religion that promote specific practices, beliefs, and values relating to sexuality and related issues such as same-sex unions, contraception, polygamy, premarital sex, and premarital cohabitation. Regardless of the source of a patient's attitudes, perception, and beliefs relating to sexuality, nurses identify these things and incorporate them into the plan of care. Recognizing client need and desire for contraception. When patients have the need and desire for contraception, the nurse must support their choices regardless of the nurse's own preferences, practices, and beliefs. At times, patients will express their need for contraception in a very direct manner, and at other times, the client may be reluctant to discuss sexuality and related issues like contraception. Nurses must, in these cases, establish trust with the patient and facilitate the client's open expression of thoughts without the fear of judgments and without embarrassment. Recognizing the expected outcomes for client family planning methods. The expected outcomes of family planning methods include the lack of unwanted pregnancies, having children when the time is right, and also having a sexually satisfying relationship. Recognizing client need to discuss sensitive issues related to sexuality. As just mentioned, sexuality can be a very sensitive issue that many patients may be embarrassed about and are reluctant to discuss. The nurse must, in these cases, establish trust with the patient and facilitate the client's open expression of thoughts without the fear of judgments and without embarrassments. Sexual dysfunction is a commonly occurring issue that many do not feel comfortable discussing because of the stigma attached to it and the patient's loss of their prior body image. Supporting the client in family planning. Family planning, contraception, and pre-pregnancy planning are integral parts of the nurse's role. Respecting client lifestyle choices. Clients, including families, make choices and decisions that affect the individual and family members in many different ways. For example, some individuals and families may choose to live in an urban area, and others may choose to live in a rural area. Some couples may choose to have large families, and others may choose to remain childless. Still more may choose homeschooling for the children, and others will not even consider it. At times, these choices impact on the individual's and/or the family's health and well-being, but nonetheless, all of these choices must be respected and supported by all healthcare providers, including nurses. Reinforcing teaching with the client on healthy lifestyle choices. Nurses determine the patient's lifestyle choices and then instruct and reinforce lifestyles instruction as often as necessary to ensure that the patient is making lifestyle choices based on accurate and complete knowledge. Self-care. Dorothea Orem developed the self-care deficit nursing theory. According to this theory, there are 3 nursing systems that are used according to the patient's abilities to perform their own self-care. The wholly compensatory nursing system consists of complete care to the patient by the nurse because the patient is not able to perform any of their self-care activities. Infants, neonates, and patients in a coma are patients who need the wholly compensatory nursing system. The partly compensatory nursing system consists of the provision of some care when the patient can perform some but not all of the needed self-care activities. A patient who is acutely ill and able to only bathe their genital area and a young child who can brush their teeth but not bathe properly are examples of patients who need the care of a nurse using the partly compensatory nursing system. The nurse cares for the needs that the patient cannot do on their own. Dorothea Orem's third nursing system is the supportive, educative, developmental nursing system. The nurse only provides assistance and education to support the patient's self-care abilities and activities. Activities of daily living, ADLs, are separated into the basic activities of daily living and the instrumental activities of daily living. Examples of basic activities of daily living include things like bathing, mobility, ambulation, toileting, personal care and hygiene, grooming, dressing, and eating. The instrumental activities of daily living are more advanced than the basic activities of daily living. The instrumental activities of daily living include things like grocery shopping, housework, meal preparation, the communication with others using something like a telephone, and having transportation. The mnemonic to remember the instrumental activities of daily living is SHAFT, which represents shopping, housekeeping, accounting and managing money, food purchasing and preparation, and the use of the telephone and needed transportation. Determining the client's ability and supporting the client for performing self-care. The patient's ability to perform self-care can be observed by the nurse as the patient performs their self-care activities. Their ability can also be determined by using the services of a physical therapist, an occupational therapist, and by using a standardized tool or test that measures the patient's abilities in terms of their basic and instrumental activities of daily living. Some of these standardized tests to determine the patient's abilities to perform the basic and the instrumental activities are the Lawton Instrumental Activities of Daily Living Scale, the Bristol Activities of Daily Living Scale, and the Katz Index of Independence in Activities of Daily Living. Abilities to perform self-care and the activities of daily living can be impacted by a number of things, including the patient's motivation, social support, physical and psychological status, their neurological status, their musculoskeletal abilities and deficits, their cognitive abilities, and their level of development. The patient's neurological and musculoskeletal status can also be measured and determined using standardized tests and tools like the Barthel Index, the Klein-Bell Scale, and the assessment of motor and process skills. Range of motion, muscular strength, muscular tone, balance, coordination, gait, reflexes, and the patient's motor function can also be determined by nurses and physical and occupational therapists. All efforts are made to support and assist patients with their activities of daily living in order for them to maintain their highest level of independence. Nurses support clients with mobility problems such as ambulation, transfers, and positioning oneself, with interventions such as assisting with and teaching transfer techniques, encouraging range of motion exercises, and supporting the patient with any assistive devices they need for ambulation, such as crutches or a cane. Nurses also support and help patients with their personal care and hygiene self-care needs as indicated. Some interventions can include setting the patient up and assisting them as needed, and also by providing the patient with assistive devices such as a long shoehorn and adapted toothbrushes to facilitate the greatest possible level of independence. Bathing self-care can be supported with assistance and the provision of devices such as a shower chair, grab bars in the bathroom, and long-handled back brushes. Toileting can be supported with bowel and bladder training and assistive devices like a raised toilet seat. Considering client self-care needs before contributing to changes in the plan of care. Nurses contribute to and consider the plan of care and changes to it as determined by their observations of the patient, their strengths, and their weaknesses. Monitoring the client's ability to perform the instrumental activities of daily living. As stated above, nurses observe patient behaviors and determine the patient's self-care needs in terms of the basic activities of daily living in the same manner as they do for the instrumental activities of daily living, including the client's ability to shop, prepare meals, and use the telephone. Psychosocial integrity. The practical vocational nurse provides care that assists with promotion and support of the emotional, mental, and social well-being of clients. The licensed practical nurse must be able to assist in or reinforce education to caregivers, family, on ways to manage client with behavioral disorders. Participate in behavior management program by recognizing environmental stressors and/or providing a therapeutic environment. Participate in reminiscence therapy, validation therapy, or reality orientation. Participate in client group sessions. Identify signs and symptoms of substance abuse, chemical dependency, withdrawal, or toxicity.